दे दो धर्मेंद्र, कुछ भी दे देना, क्लास चल रहा है।
Good morning to all. I, Dr. Amit Agrawal, Consultant Department of Telemedicine, feel privileged to welcome our esteemed Director, Chairpersons, speakers, and delegates for today's Foundation Day CME on COVID-19 and telemedicine. On behalf of Department of Telemedicine, we hope you are keeping safe in this COVID time. This year, we are celebrating Foundation Day of the Department on the auspicious occasion of Baisakhi and beginning of Navratra. Now I invite Dr. Harnoor and Ms. Parinita to present bouquet to our esteemed Director, Professor Jagatram sir, and to Dean sir, Professor J.D. Puri sir. Thank you, sir. Now I request Professor Minu Singh, Madam, Head Department of Telemedicine, to give welcome address.
Honorable Director, Professor Jagatram, our worthy Dean, Professor J.D. Puri, and all other esteemed guests who have joined us online. It's a privilege for me to welcome you all to this Foundation Day CME of the Department of Telemedicine. During this journey of last 15 years, we have come a long way and have made several friends. The galaxy of speakers that we have today all helped us shape the telemedicine services in PGI and also in other parts of the country. I'm still reminded of the hustle and bustle of 13th April 2005 when Professor K.K. Talwar got the Telemedicine Center inaugurated by the then Prime Minister of India, Dr. Manmohan Singh. That was also a Baisakhi day, and he had visited the institute for the convocation. The center and then the department since 2015 has rendered service which is recognized nationally and internationally. Notable amongst these are SARC Telemedicine Network, eSanjeevani Development with Center for Development of Advanced Computing, Mohali, collaboration with Bhabha Atomic Research Center, WHO and ICMR, and of course the patronizing role of Ministry of Health and Family Welfare, who designated us as Regional Resource Center for National Medical Colleges Network and for tele-evidence. Actually, Ministry of Health and Family Welfare has actually been advising us on how to conduct services. And today we were going to have Mr. Love Agarwal as one of our key speakers. But we were informed yesterday and also today morning that they have a meeting with at the PMO, so they have to leave. So they will not be joining us. But we still have amongst our star speakers, Dr. Sanjay Sood, who will be joining us, and he's done tremendous amount of work developing eSanjeevani. Now, during the COVID times, the center has been conducting EMR-based teleconsultations, tele-education, regular evidence-based COVID seminars on YouTube, helping other departments conduct MD, DM exams, as well as PhD vivas. We are continuing with our research activities, and I think the CME today, with the theme of COVID and telemedicine, will enhance knowledge in fighting the pandemic. Although the times are difficult, let us see what we can contribute. With those words, I thank you all for joining us, and I welcome you to the CME today. Thank you very much.
Thank you, ma'am, for your insight knowledge. Now I request Professor G.D. Puri, Dean Academics and Head Department of Anesthesia, to give his address.
Professor Jagat Ram, Professor Saroj Mishra, Dr. Meenu Singh, other dignitaries who have joined from the various centers across, Dr. Agarwal from Banaras, Professor Mr. Sabu, and other dignitaries from the different parts of the country who have joined us in this auspicious occasion of the Foundation Day of Department of Telemedicine. The history of telemedicine in India goes back to the mid-90s when the Department of Electronic and Information Technology and the CDAC Noida, they set up the first hospital information system software at SJPGI. Dr. Saroj Mishra is one of the speaker today, and probably he'll highlight that the first the telemedicine centers was set up there and pilot center, and similarly the pilot project was started at PGI Chandigarh in 1999 with Dr. Gupta as the torchbearer for that setup in those days. With the initial hiccups and slowly this
कॉन्टैक्ट में रहो सर आना
all over the
ठीक है क्योंकि कोविड के चक्कर में केसेस बंद कर दिए मतलब लिमिटेड केसेस ले रहे
and subsequently PGI has been one of the resource center for the northern India, and Dr. Meenu Singh is spearheading for last many years this facility at telemedicine. I must congratulate Professor Meenu Singh for this CME and for the foundation day of this center. In the current times, when telemedicine is providing care to patients remotely, in a situation when both providers as well as the patients are not able to be present physically with each other, either due to fear of transmission of infection or the travel restrictions, which the government imposes from time to time to prevent the spread of infection. The relation between the health and technology goes back to the time when the telephone was invented, and from those days the teleconsultations have been going on in a minor ways. But with the development of technology, the video calling and WhatsApp and other things, for last 3 decades, it has multiplied many folds. And example is that PGI has been providing telemedicine, teleconsultation services to hilly areas, to remote locations, Leh, Ladakh, etc., for many years. Though initially this telemedicine, the use was felt while dealing with patients in remote locations like ships. People used to go for cruise on the ships and the people get sick. So teleconsultation and medicine was practiced very well there. And now this pandemic has not only given us the challenges, but also provided us opportunity to exploit this mode of healthcare delivery to the maximum. Presently, if we see the market, it is somewhere around, before the pandemic, it was around 35 to 40 billion dollars, and now it is expected in the next 5 years to grow almost to $200 billion. And majority of this is 60% is in the providing services, while 30 to 40% is the medical devices. Every specialty, though the dermatology, pathology, mental health, and radiology were the first to exploit this telemedicine facilities for patient care. But now with the remote cardiac monitoring, this has given a possibility for quick diagnosis as well as quick referral and management remotely with the use of telemedicine. With the increase in the bandwidth and ease of sending the images across the world quickly, so the surgeons as well as the physicians sitting 1,000 miles away can not only guide the surgeon and the physicians, but also make diagnosis for the critically ill patients. So the opportunities are great. We have to lap onto it, and we need to, and each department, each specialty has its own unique way of exploiting that. As I said, from the simple teleconsultations to telemonitoring and interventions. And so not only in the last 1 year, but we have found that not only it has decreased the congestion in our OPDs, but also has provided better facility to the patients who can communicate with the doctors sitting at home without wasting time during the travel, without losing their privacy and wasting time sitting in the congested OPDs. So I'm sure Dr. Minu Singh and her team will latch on this opportunity, and the government is already providing the full support to exploitation of this telemedicine and telehealth. The future is bright for this specialty, and for this technology development, we need to cooperate with each other maximally. With this, I thank you, Dr. Minu Singh, for inviting me as a part of this this Foundation Day, and I wish you all the best for this CME as well as for the future. Thank you.
Thank you very much, sir, for your valuable words. Now I request Professor Jagat Ram, sir, Director of the Institute, to give inaugural address.
Professor G.D. Puri, Dean Academic PGI, Professor Minu Singh, Head of the Telemedicine Department PGI. We have with us Professor Nusrat, Professor Viman Sekia. Online we have several guests, Professor K.K. Talwar, Advisor to Government of Punjab and former Director PGI. Dr. Sanjay Sood, Project Director E-Sanjeevani and Associate Director CDEC Mohali. Professor N.K. Agarwal and Professor S.K. Mishra. We have other senior member, Shri R.K. Sabu, former President of the Rotary International and presently our Honorable Member of the IB, and dear friends. First of all, I welcome all of you to this auspicious occasion of Foundation Day of the Telemedicine. This year theme is very appropriate, that is COVID-19 pandemic and telemedicine. I think we must congratulate the Department of Telemedicine. They have done outstanding work for the last 1 year in teleconsultation during this COVID-19 pandemic. The telemedicine department, as said earlier, was started in 1998, initially in this institute, and since 1998, it is continuously progressing and doing excellent work. It is now providing teleconsultation to all over the country through NKN and ISRO network. It is designated as the Regional Resource Center, North India, by Ministry of Health and Family Welfare, Government of India. The other services are also being started, like tele-education and tele-evidence services. The Department of Telemedicine was also a part of the telemedicine SARC network. Department of Telemedicine already provided more than 50,000 consultations till date in Punjab only, and more than 50,000 consultation in COVID period for the last 1 year. Hundreds of the education sessions have already been telecasted. Ayushman Bharat Health and Wellness Center hub also been established in the Department of Telemedicine from different states for providing teleconsultation. It will be really helpful in reducing the burden of the patients patients in PGI in the near future. Even currently, it is doing excellent job, and part of the rush is reduced due to teleconsultation. Tele follow-up of the patient is also need of the hours, and we are in addition to the new patients, we are following up the patients, our former patients who are surgical and medical on the telemedicine. Recently, almost all the clinical departments are using telemedicine services. Even our MD, DM, MCH examination, webinar, orations, PhD Viva, and other academic activities for different departments of the institute is being done through Telemedicine Center. Department of Telemedicine is doing remarkable job, and I'm sure that soon we will be able to start the National Institute of Telemedicine in the near future. I congratulate Professor Meenu Singh for her continuous efforts and doing excellent job for the progress of the Department of Telemedicine. Thank you very much.
Thank you, sir, for your kind words. Now I request Professor Vimal Sekia, Department of Immunopathology and Nodal Officer of PGI Punjab Telemedicine Project for vote of thanks.
Good morning, everybody. It's my proud privilege to propose this vote of thanks for this Foundation Day CME of the Department of Telemedicine. And at the outset, I'd like to thank our director, Professor Jagatram, for having spared his valuable time and attending and delivering the inaugural address. And I'd also like to thank Professor G.D. Puri, Dean Academics, for his address and the time he's taken out for this function. And I'd like to thank the other dignitaries who are present and attending this CME today, Professor S.K. Mishra, Dr. Sanjay Sood, who is going to give us the Foundation Day lecture very shortly, Professor K.K. Talwar, Shri S.K. Sabu, and thank you for being there with us. And last but not least, I'd like to thank Professor Meenu Singh, the main person behind this whole project and pushing telemedicine to the position that we have it as of now today, and her entire team especially Dr. Nushrat. We have Dr. Nushrat here, and Mr. Amit Agarwal. You have done an excellent job in organizing the CME. And so we have a very interesting program today, and I'd like to thank all the speakers who are going to participate in the deliberations in the next 2 hours. And thank you for participating and agreeing to be part of this CME. Thank you so much. Thank you all. Thank you.
With this, we have come to an end to our inaugural session, and we will be beginning again at 11 a.m., which is about 10 minutes from now, when we will have our Foundation Day lecture. So you can actually relax for 10 minutes. Thank you very much. good morning, everyone. We will be now starting our first session, first academic session, which is the Foundation Day lecture. This lecture is going to be chaired by Professor K.K. Talwar and Dr. B.S. Bedi from Professor K.K. Talwar. Everybody knows him in PGI. He is the former director of PGI, a Padma Bhushan. He's a renowned cardiologist internationally and is currently the advisor to the government of Punjab and is actually coordinating all the efforts to control COVID in this state. He's been former chairman, Board of Governors, Medical Council of India, and is currently in New Delhi. He's in the PSRI Heart Institute for his practice. He's received several awards, as I said, besides Padma Bhushan, B.C. Roy National Award, R.A. Bhatt Award, Basanti Devi Amirchand Award of ICMR, and Ranbexy Research Award. There's a long list which we cannot complete. Welcome, sir. Welcome for chairing this session, which is by Dr. Sanjay. We also like to welcome as chair Dr. B.S. Bedi, who is the advisor to Ministry of Information and Technology and to the Center for Development of Advanced Computing. He is the person who has been instrumental in starting the CDAC, which is several centers which are there all over the country. And the one which is in Mohali has been, who has come out with eSanjeevani, a software which is currently being used all over the country for teleconsultations, especially during the COVID times. Dr. Bedi has been actively involved in policy development programs of IT in health initiatives of Ministry of Health and Family Welfare. He has been conceptualizing, evolving, and implementing a number of major schemes involving electronics and IT applications in different sectors with major focus in healthcare. He is the past president, Telemedicine Society of India, and executive member of Indian Association for Medical Informatics. He is currently the advisor, Health Informatics, to the Center of Development of Advanced Computing. So we'll now be starting the lecture, and we have as a lecturer Dr. Sanjay Sood, and I'll request Dr. Bedi, sir, to introduce Dr. Sanjay Sood.
Good morning, everybody. And I thank PGI Chandigarh, Dr. Meenu Singh, for inviting me for this event, very important event. The PGI has been one of the pioneering institution where, my program starting in DOE, it was one of the leading institute which, see, I would like to say a few things before I, introduce the speaker. It was way back in 1998, 99 when, our first interaction with the PGI started for telemedicine. And that time the initiative from PGI taken was by Dr. B.D. Gupta, a very close friend. And also, see, I am very, very happy that it is not only telemedicine which was started, but way back earlier, the proactive initiative by PGI Chandigarh, from Ministry DOE in those days, Ministry of Electronics and Information Technology was called Department of Electronics. We had supported development of a linear accelerator. Linear accelerator, those days only cobalt therapy was given to the cancer patient. And excellent work was done by Samir and CSIO Chandigarh in producing this first linear accelerator for cancer therapy, 6 MeV linear accelerator. So I'm very proud to say that India was the fifth country in the world, fifth, sixth country in the world, and it was the graciousness of PGI Chandigarh who made a full establishment to have that linear accelerator. They made the full arrangement and a meticulous record of its FEKC which turned out to be very, very good. It was an excellent indigenous, but credit to PGI Chandigarh, who kept a total record, Dr. P.S. Negi and Dr. B.D. Gupta. See, that was this thing, then, our interaction with PGI kept on increasing with, they're taking a lead role. And when we set up the first network to try the indigenous, our support was for the indigenous product development and network, where, just for experimental purposes, PGI Chandigarh was connected to Shimla Medical College and AIMS with Rohtak Medical College and SGPGI Lucknow with Cuttack Medical College. See, it is, I don't have to emphasize how important telemedicine has become in the present scenario. It was earlier used for connecting the remote people to facilitate healthcare delivery to them. But interestingly, now it has become all prevalent. I can tell you, even people staying in the urban areas, they can have access to the doctors through telemedicine. I think Sanjay Sood will be talking about those things in much more detail. One simple personal experience of this COVID. In November, I personally got sick, was down with COVID-19. And then, I preferred a home isolation. I took a teleconsult home package, home care isolation package with a very reputed medical hospital chain. And it was interesting that, I will have occasional every 2-3 days teleconsult with the specialist and also teleconsult with the nurse, which that was a regular this thing. No doubt, I just it reminds me of a couplet which कुछ गुनाहों की सजा अब साथ चलती है, अब हम तन्हा नहीं चलते, दवा भी साथ चलती है. So this is one thing, which telemedicine is doing to the country, and our time is not far when it will be all prevailing. Already it is become so common, such a common practice. Now, I will just like to, it is really my pleasure to introduce Sanjay Sood, who has been, a part of my CDAC team, and, we did some R&D support program so that, our indigenous platforms get developed. He was part of the team in that time when Dr. R.S. Kanpur and B.S. Bhatia, they were the main leaders, and CDAC was called CEDT in Mohali. But then it became CDAC later on, and I'm so proud that the support which we from ministry gave resulted in this platform, Sanjeevani, and my kudos to the team who worked on it, and as the mobility of the devices instead of the huge platforms, mobile technology took over, and they, with their constant effort and have effort supported by the Ministry of Health, they came out with a very EMR standard, conforming e-Sanjeevani product. So, which you are all aware how it is really helping the country in taking tele-healthcare to the common person. Now, Dr. Sanjay Sood, he has a very bright this thing. So he was, as I told you, he was part of the telemedicine team from CDAC Mohali. But he has contributed many things in telemedicine, not only in India, even outside. Currently, he is project director e-Sanjeevani, India's National Telemedicine Service, and he is associate director in CDAC. I would like to tell some of the major achievements which Dr. Sanjay Sood had. He led the implementation of the 5 telemedicine network overseas and 2 statewide telemedicine networks in India, besides setting up e-Sanjeevani, which is Southeast Asia's largest telemedicine network. He was awarded Digital India Award for this Sanjeevani program by Government of India in 2020. He was also given state award by Chandigarh administration, and a split of HIMSS by Healthcare Information and Management System Society, USA. And I'm proud to say he has authored 50 class publications in various reputed journals all over the world. So this is Dr. Sanjay for you, and my very old bright young man who has now assumed such important role. Dr. Sanjay Su.
Thank you very much, sir. At the outset, I would also like to thank Director PGI Professor Jagat Ramji, Professor G.D. Puriji, the Dean PGI MER, and Professor Meenu Singh Ji, who's heading telemedicine setup at PGI, and Dr. Bimanji as well, the nodal officer, for giving me this opportunity to share my views or experiences here today. And I must also say that it's a huge honor to be introduced by personalities who are sort of your role models and who are no less than celebrities in their professional domains. So thank you very much, Bedi sir and Dalbar sir, for the introduction. And I do acknowledge that majority of my practical learnings about the user side of telemedicine have come from PGIMER, and I'm really proud to have been associated with such a premier institution to which the whole country looks up for all sorts of I would say clinical challenges, and PG has always stood tall and addressed all the concerns and challenges that the populace in this part of the country has ever had. And I would also like to additionally acknowledge that my learnings about what kind of telemedicine do clinicians want started way back in 1998, as Bedi sir has talked about, under the aegis of Professor V.D. Gupta ji, one of the leading oncologists of his times, who sowed the seeds of telemedicine at PGIMER Chandigarh during the days when Bedi sir was really very, I would say, instrumental in conceptualizing the fact that India must have its own indigenous telemedicine technology, and that was the birth of telemedicine, so to say, in the country for an indigenous telemedicine platform, which not even the developed, many developed countries did not have. And then after that, the baton was carried by another eminent clinician, Professor S.K. Jindalji, a pulmonologist at PGI Chandigarh. And now, as we all know, the torchbearer being our forward-looking clinician, Professor Meenu Singh Ji, who's again a celebrated pediatrician amongst us. Well, although I'm not a clinician, still I think you all would agree with me if, based on the extant literature, our medical literature, I say that many studies and cases have projected medical care as fragmented care. Why would medical care be linked with or related with fragmented care? There are numerous reasons that the researchers or the experts or even the practitioners they've cited, and these include that medical care has added close to around 100 specialties in its bouquet of services in past 40 or 50 years, and there have been very fine boundaries which separate these specialties, and many clinicians have claimed that each of these specialties operate in some sort of silos, and because of those kind of situations, to give a patient-centric care, eventually newer concepts of care like medical teams, transition care management, etc., are trying to interconnect these silos and in medical care, and the patient care is thus getting better and better than ever before. Maybe this is the way it works in medical care. We being from the technical side, we have very little understanding about how or what the dynamics within the medical domain exist. So we can only translate what we understand or what we are fed or what we are taught or what we learn from the forward-looking clinicians. And I guess when telemedicine started way back in 1998 in the country, or rather in the government sector in the country, we can say that in past 20 years it has evolved significantly, and especially in the public-owned health delivery system. So far, till around 2019, I would say that it has been a disjointed existence in the entire country, specifically in the public healthcare delivery system. Once again, I would like to point out that. And I'm sure that after 2019, the direction in which the course of telemedicine implementation and the usage has moved, it is all going to be something which has a very bright future, and which certainly will take the whole domain of the clinical care or medical care to a level where the patient gets the best of the services, or the best of the care that has ever been anticipated or ever been expected in a clinical setup, or even at home. So to start with, when we deployed Sanjeevani way back in 2002, I guess it is certainly the country's first indigenous telemedicine technology, and we connected PGI Chandigarh, AIIMS New Delhi, and SGPGI Lucknow, wherein Professor Mishra, who's been really instrumental in carrying forward the initiatives of telemedicine all across the country. And these three leading hospitals were connected for the pathologists, cardiologists, and radiologists to practice telemedicine in their domain with their peers in the other institutions. And then this practice grew slightly further to the next level, wherein few more peripheral hospitals were connected in the same Sanjeevani network. And in 2005, 6, and 7, again under the aegis of Bedi sir, we were fortunate enough to get an opportunity to put together statewide telemedicine networks using e-Sanjeevani then, because internet had become really prevalent and ubiquitous. So that is what led us to have basically a version which was online, or which could be accessed through internet. Earlier, it was a standalone application. So the silos, I think the foundation for the silos which were existing in the public health sector continued even after the onset of internet. We had Punjab's telemedicine network. We had a Himachal Pradesh statewide telemedicine network. ISRO had its own implementations, and a few other state governments between 2006 and 2018. Numerous states like Uttar Pradesh, Rajasthan, even Madhya Pradesh had been making some efforts. Gujarat did. Tamil Nadu also did. Telangana is already doing separately. So they all had their own telemedicine networks, which grew in some sort of silos, to which the Ministry of Health and Family Welfare, even the experts in the Ministry of Electronics and IT, they recognized that this certainly is not going to be of great importance, because in times to come, data is certainly going to be the most important component in the entire electronic or digital ecosystem, and hence the decision was taken to ensure that we must have one nation and one application, or one telemedicine platform across the country. And it was, I think, in 2018 that under the Ayushman Bharat scheme, the Ministry of Health and Family Welfare decided that this one model application telemedicine platform has to be put in place, which will not only extend the benefits of Ayushman Bharat scheme to the rural India, but also would enable the interoperability between the states, or between various healthcare service providers, be it a medical college, be it a tertiary level institution, or be it a PHC or a CHC or even a subcenter. So accordingly, the telemedicine was seen as just one umbrella platform that needed to be set up. And the Ministry of Health and Family Welfare conducted a nationwide survey of all the telemedicine platforms in the government sector. Those were available. And based on our learnings, eSanjeevani was sort of an application which was really very popular amongst the clinicians wherever it had been implemented. And I think the feedback from the clinicians specifically, I would say, from the team that is headed by Professor Meenu Singh ji and even Professor Mishra ji, it helped the policymakers and the decision makers at the Ministry of Health and Family Welfare to pick eSanjeevani as the popular telemedicine application, so that the doctors could easily step on to or get on board this telemedicine bandwagon, and eSanjeevani could be shaped up as the national telemedicine service. So in 2019, we rolled out telemedicine application nationally. Just a moment, sir. Amitji, I do not have access to share my presentation in case I could be.
Sir, so the rights are given to you for the sharing. Below your screen, there is a button like share.
Okay.
There is 3 buttons: unmute,
Yes,
stop mode,
but that
video,
is not
and share.
active. That particular.
It is active, sir. Active for all.
On my end, share is disabled.
I don't know.
Dr. Sood, if you could just continue, because we are really enjoying
Okay,
your
ma'am,
talk.
I'll continue without the presentation. I'll continue without presentation
Yes.
itself. I think
Yeah.
it'll be quite comprehensible otherwise as well. eSanjeevani, that was decided to be rolled out as one application across the nation, was primarily meant to connect or to work as a doctor-to-doctor telemedicine platform, which was aimed to address the shortage of doctors and specialists at the ground level, and then and also meant to reduce the burden on secondary and tertiary level hospitals. And then it would also lead to some sort of boost in the digital health ecosystem in the country, especially at the ground level, because in those days, or rather in 2019, the patient to doctor telemedicine was not legitimized, and I would say it is COVID that gave that propulsion or projection or push to the telemedicine practice. That in 2020, March 25th, the then Medical Council of India and Board of Governors there, they legitimized the practice of telemedicine or remote teleconsultation between a doctor and a patient. That the patient to doctor telemedicine was born, and eSanjeevani's rather our team was pressed into service by the Ministry of Health and Family Welfare in March last year. And we were asked to put together a patient-to-doctor version of eSanjeevani at the earliest, because the OPDs across the country were closed down because of the first lockdown, which started somewhere in the last week of March. And since then, I would also like to seize this opportunity to state that today, eSanjeevani, the National Telemedicine Service, that is the patient-to-doctor service, the eSanjeevani OPD, completes 1 year and exactly 365 days. It is on 13th April last year, we launched eSanjeevani in 4 states, Andhra Pradesh, Uttar Pradesh, Assam, and Maharashtra. And since then, there has been no looking back from the time we launched, and the states, as well as the Ministry of Health and Family Welfare and other premier institutions like AIIMS Bathinda, AIIMS Rishikesh, AIIMS Bibinagar in Telangana, and Lady Hardinge Medical College, Government Medical College in Chandigarh, and even King George Medical University in Lucknow, and CGHS. And institutions like these have come forward and opened their telemedicine services or online eSanjeevani OPD, and they are extending services to the populace in the region around them. So till date, we have in eSanjeevani network, we've done close to around 4 million consultations, 3.97, and today we are expecting to complete 4 millionth consultation sometime, maybe by 3 p.m. or so. That is our anticipation. On doctor to and this entire application is being used in 31 states and UTs in the country. Few more are in the pipeline, and they'll be joining the network very soon. In the doctor to doctor variant, eSanjeevani, we have 23 states those are using, and they have already onboarded around 20,000 users, which include community health officers, doctors, medical officers, and specialists in the network. And we've done around 1.38 million consultations in that network. And on the other hand, eSanjeevani OPD, which is a patient-to-doctor variant, it is operational in 28 states, and we have around 15,000 doctors already practicing telemedicine on eSanjeevani OPD. We've done 2.6 million consultations on eSanjeevani OPD. So together, we are very close to 4 million, the mark of 4 million. And as regards the eSanjeevani Ayushman Bharat Health and Wellness Center, which is the doctor-to-doctor telemedicine platform, we are having connectivity between the sub-center, which are being transformed into health and wellness centers. And these sub-centers are getting connected with the medical officers either at PHC, or in case the medical officers are not at PHCs, then the sub-center or the health and wellness center is mapped with a medical college or a tertiary level institution like PGI. PGI is also one of the hubs on eSanjeevani's Ayushman Bharat Health and Wellness Center model for Haryana. And similarly, the rural populace, whosoever walks in a health and wellness center, is able to consult a specialist or a doctor through eSanjeevani without having to walk out of the village, without having to spend money to travel or kill their daily wage, or wait in the queues for their turn. So eSanjeevani has not only reduced the distances, it has also saved a lot of money, which is already a scarce resource in the rural population in the country. And on the other hand, in eSanjeevani OPD, based on the directions from the eHealth section led by Shri Love Agarwalji at the Central Ministry, we were given few guiding philosophies that the OPD, patient to doctor variant, because this was for the first time we were going to attempt that, had to mimic the traditional telemedicine or traditional hospital-based OPD system. Yes, please. All right. And the guiding philosophies were that the eSanjeevani OPD telemedicine platform must mimic the traditional hospital OPD that exists in any public health health setup. And the other guiding philosophy was that it has to be a user-friendly, because it was a public-facing service of first of its kind to be offered to the populace in India, and it had to be secured so that people feel confident and encouraged to use this platform. And we enabled that in a very simple 4-step manner process, wherein the patient would register using a mobile application in Android phones or web application, generate a token, and then closer to the turn, he or she would receive a notification saying that your turn is about to come. You may please log in into the system. And as soon as the patient logs in, gets into the queue, and depending upon the number of doctors serving that OPD, the patient's turn comes in around, on an average in eSanjeevani OPD network, the patient wait time is around 10 minutes, less than 10 minutes. It is 9 minutes, few seconds. And once the patient turn comes, he gets connected with the doctor on the other end, and the doctor then speaks with the patient, examines the patient virtually, and writes down the e-prescription, explains the e-prescription, and closes the call. So as of now, we have over 260 OPDs. Those are functional on eSanjeevani OPD, out of which around 35 are general OPDs. 225 or 30 plus OPDs are either specialty or super specialty OPDs. And the e-prescriptions those are generated in eSanjeevani, both the variants. They have been sort of validated or formalized by various state health departments in their states as formal prescriptions, and they are honored at all the chemists and pharmacies based on the orders. Those have been released by the drug controller in the state. And if we look at the trend in eSanjeevani, we were doing in November 19, when we rolled out doctor-to-doctor variant, we were doing 3,000 consultations in a day. And we rolled out eSanjeevani OPD in April. And now, in a month, 3,000 we did. In the first month, we did 3,000 consultations. And now in March, last month, that is, we've done close to around 1.07 million consultations in 1 month alone. And in the month of March, we were doing around 40,000 consultations a day. And on Sundays, also few states are working. States like Karnataka, Tamil Nadu, Kerala, Gujarat, they are operational on Sundays as well, and even on national holidays. So that's a very, which is gifted to the populace, that the outpatient departments or the OPD, online OPD, is functional even on Sundays and national holidays. That makes it 365 days operational, and on every day from 8 a.m. to 9 p.m. eSanjeevani is working, and we are providing all the support. And just yesterday, we almost touched 50,000. We've done 49,000 and few consultations, and we are expecting to touch 100,000 consultations within this year, and we are looking forward to complete 10 million consultations in the month of November. And this certainly would be a great accomplishment for the public sector or public-owned telemedicine community in the country. And as of now, the states are rolling out numerous innovative applications, clinical applications on eSanjeevani, whereas we just put together a general consultation platform. So they've transformed into a very specialized and a very unique and a very, I would say, convenient format of delivering health services. The state of Kerala has put together district early intervention centers, which is a part of Rashtriya Bal Swasthya Karyakram, wherein the children growth is monitored, or the issues pertaining to children growth, they are addressed through eSanjeevani, wherein 4 specialists, and including a physiotherapist or psychiatrist and other experts attend to the queries by the parents and the children. And eSanjeevani is also being used as a monitoring platform for COVID-19 patients who are quarantined at home. And eSanjeevani has had the opportunity to save lives by enabling the doctors practicing on eSanjeevani and identifying the cases through video consultation when they came up for consultation for a general OPD consultation, that the patient is having a stroke, and immediately the patient was transferred to the nearest health facility by getting an ambulance sent to the patient's home. And that is how eSanjeevani is also saving lives. And in the state of Kerala and Tamil Nadu, HIV/AIDS clinics have been set up on eSanjeevani, and in Kerala and Himachal Pradesh also. And the Honorable Health Secretary, Shri Rajesh Bhushanji, has already advised all the states to use eSanjeevani for the inmates in jails, inmates in orphanages and old age homes. And in Kerala, they are already providing health services to the inmates in the Palakkad district jail by using eSanjeevani. And we can say that there are around 10% of the users of eSanjeevani, especially patient-to-doctor consultations, are from the senior citizen bracket. And we have close to around 35,000 users, that is doctors, who are practicing in the eSanjeevani network, which is supposedly the largest in the world. We've not come across any telemedicine network with this kind of traction by the medical community. And we can say that in the country, telemedicine is not only increasing the access of specialized care to the rural areas, but is also ensuring continuum of care, and is also improving the health indicators. Not only the health indicators, but also improving the economy, because we are saving a lot of patients' productive time, and we are we are not letting patients to travel all the way to the specialist or a medical officer. We are also enabling the bridging the gap that exists in the healthcare or the digital health divide between the rural and the urban parts of the country. And of course, telemedicine platform like eSanjeevani is boosting the digital health ecosystem in the country as well as in the government sector. And eSanjeevani's success has led to 3 more huge telemedicine instances which are in the pipeline. Within next 4 weeks, we'll be rolling out, or rather, our Raksha Mantri will be inaugurating the telemedicine platform designed or powered by eSanjeevani telemedicine core engine, which is called Sehat OPD, services, e-health assistance and teleconsultation for the tri-services in the country. So all the working defense personnel and their dependents will also have a platform very much like eSanjeevani that is called Sehat OPD, which will go live, which is already functional as a POC in a very basic format since May 2019. 2020, we set it up for them after eSanjeevani, and the full-fledged Sehat OPD will be rolled out within next 2 or 3 weeks, and the development has completed, and we are working towards putting together the last components and testing and ensuring that the things are in order, because it is for the defense services. And we are also working with Ministry of External Affairs to put together Arogya Bharati, very prestigious program of Government of India, which will connect all the African countries with the specialists in hospitals like PGI Chandigarh and AIMS New Delhi, and STPGI as well. And we've already run a POC with AIMS New Delhi and PGI MER here with Meenu ma'am's team. And the third network that we are conceptualizing now is with NACO, that is National AIDS Control Organization, which is already assigned us the task to put together a national HIV telemedicine network for the country, wherein we'll be connecting the Center of Excellence for AIDS with the ART centers in the country. So it will be again a doctor-to-doctor telemedicine that we'll be putting together. And in around 6 months to 9 months from now, the country or India will be the first national country to have a national HIV/AIDS telemedicine network as well. And in the process, we've been, eSanjeevani platform has been recognized by Government of India, by Scotch Group, by Computer Society of India, and by a few other organizations for the kind of innovation it is, and for the services that it is imparting, and for the social impact that it has led to. And in the future, we are looking forward to telemedicine in a big way. eSanjeevani will support multilingual interface, which will enable deeper or larger adoption of eSanjeevani amongst all the sections of the populace in the country. And we are also working towards having eSanjeevani on feature phones as well as on landlines, because as of now, the internet penetration in the country is around 37%. So we are still not accessible to populace that is beyond 37%. So 2/3 of the population still is devoid of telemedicine services, although the state governments have made provisions at community health, at sub-centers, wherein the community health officers are enabling access to the populace who do not have feature phones or access to internet by providing them the consultation through their devices, tablets and smartphones. And ASHA workers are also going from door to door to check with the families in the villages and get them connected through eSanjeevani using their tablets. And that is how the government is, or the state administrations are supporting telemedicine in a big way. And we look forward to, again, all the forward-looking clinicians who have already, shown the way to the whole world that telemedicine can be used very, very beneficially and can extend the access of specialized care even in the rural areas. With this, I thank you all for giving me this opportunity and for patient listening. I'll be very happy to address your queries. Thank you very much.
I think it is already quite late, Sanjay.
Thank you. Yeah, thank you very much. Yeah.
Pleasure.
Thank you
thank
very much, Sood sir, for an illuminating talk. I would now request Professor Talwar to give his concluding remarks for this particular talk.
Thank you so much, Dr. Minu, and I think it was really a treat to listen to Mr. Dr. Sood for his contribution into this area. I can only say as a clinician that but for this teleconsultation or telemedicine, I'm wondering what would have been the fate of patient in the last 1 year. COVID has really taught us strong, and I am sure in the post-COVID area, this is going to continue as a complementary to the, of course, physical contact is very important and between doctor and the patient, but I'm sure this is going to be a complementary way to the our managing patients in the future also. I must also mention today that I mean this is a very auspicious day for the Department of Telemedicine and PGI. It was in 2005. 30th April, the Baisakhi Day, that our Honorable Prime Minister then inaugurated the activity of outreach activities of PGI through telemedicine. And we were connected to 5 centers in the Punjab with the help of ISRO, who gave all the infrastructure. So I think that was the beginning of outreach consultation from PGI. That was, of course, mainly limited to doctors and doctors. But I think subsequent what is happening, I think is a congratulate Dr. Minu also for sort of strengthening this particular department and what we can achieve today through this kind of services. I think again I congratulate Dr. Sood for all your contribution in the field, and I'm sure telemedicine is going to be part of the future as far as a clinician. I mean, we have a my health system that I have been loaded on my um, smartphone, and I tell you daily few patients I have to handle, and I know you can load your record on that. You can see the patient's record. You can write back and send him the prescription. So all this is possible all because of the contribution of people like you. And thank you, Dr. Bedi. Also, I think he has been a great help to PGI all the time when we were developing our telemedicine as well as our computer facilities. Thank you so much, Dr. Minu Singh, for this opportunity. I'm sure your session is getting late. So kind of you for this opportunity again. Thank you.
Thank you, sir. Thank you very much for participating. Really thank you and Idi sir and Dr. Sood for giving such a stellar talk. And we can really see that on this particular day, you will reach your 4 million mark, and which will be a great achievement for eSanjeevani. So it is now actually eSanjeevani Day also, it looks.
Exactly.
So with that, yeah, we will not have any questions in this particular session. And we would like to close this particular session now. Thank you very much. And we'll move on to the next session now, which is a panel discussion, which will be chaired by Professor Savita Malhotra. Professor Savita Malhotra is actually a former dean of PGI, and she's actually a pioneer in the field of telepsychiatry. And it was her project by DST which brought in a diagnostic algorithm for diagnosis of psychiatric disorders. She was also a great help to us in PGI because she helped us write the proposal for National Institute of Telemedicine and got it approved by the academic committee and the governing body. So we really owe our inception of this particular institute to Professor Savita Malhotra. So I request ma'am to chair this session and invite the speakers.
Thank you so much. Thank you very much, Dr. Minu Singh. It's my great pleasure and honor to be on the dais today on the PGI floor. Dr. Minu Singh, Dr. Biman Saikia, and your entire team, other faculty colleagues of PGI. And I see today here on the program, officers of the Ministry of Health and Family Welfare are also there. Eminent speakers, I see Mr. Bedi here and other participants, colleagues and friends. It's a great pleasure for me to be here sharing the celebrations of the Foundation Day of Telemedicine Department of PGI.
Ji, sir.
And is there a disturbance?
मैं देख लेता हूँ शायद email में था जो email आई थी सर.
Can you unmute, please, the other mics? Okay. And thank you
I
very much for
request all
inviting
other
me.
speakers to mute their mics. Yeah.
So PGI, I'm pleased because PGI is my alma mater, and telemedicine had become my passion during the later part of my stay in my professional life in PGI. I was, I must say, inspired and nudged by none other than Dr. B.D. Gupta way back in 2002, who talked to me on a shared Shatabdi journey from Delhi to Chandigarh about the potential and the promise of telemedicine. And he was at that time, already telemedicine project was already going on in PGI under him. And so 2003, I wrote a project in telepsychiatry in 2003 for Ministry of Electronics and Communication, which was not responded to. And then Department of Science Technology actually responded. And then we did a project under that. And we were able to establish a system of telepsychiatry. You know, I will talk about it a little later. That is a system of automated diagnosis and management for mental disorders commonly seen in the country. And this was possible to be done by the non-specialists because psychiatrists are so few in the country. So non-specialists could operate and use this system, the clinical decision support system, and we named it as Psychiatrists on Web. So this was almost a psychiatrist, virtual psychiatrist sitting on the web, and who could be accessed and used by non-psychiatrists and specialists to arrive at a very credible and accurate diagnosis and management guideline for patients. So that is where we were. And today I am here, Dr. Meenu Singh has invited me over to chair this panel discussion. And the topic for this panel is the management of healthcare services, delivering healthcare services in this COVID-19, and how telemedicine can be deployed and used for delivering services in the COVID times. We have 4 panelist speakers here today. And I also have my co-panelist, Shri Rajesh Bhushan, Secretary Health Family Welfare. Is he there, Dr. Meenu? Is he there?
No, ma'am. All the ministry officials had to go for a meeting in PMO, so they are not there.
Okay, so he's not there, so I am by myself, all right. We have on the panel today 4 speakers. So that means we also will not have Mr. Govind Jaswal. Dr. Meenu.
Yes, ma'am. He's also not there. So
we have 3 speakers. So we have 3 speakers and we have about 45 minutes.
Yes, ma'am.
And we have about 45 minutes of presentation. And I'm very pleased to introduce the first speaker in the panel discussion today, Mr. Rajendra Sabu. He's the Chairman Emeritus of KDDL Limited. We know him in the city of Chandigarh as the ex-Rotary head and a philanthropist, a welfare activist, and a supporter of all the welfare activities in the city of Chandigarh. He's a Padma Shri awardee in 2006. He had a degree of Doctorate of Letters by H.N. Bahuguna Gadwal University, Uttarakhand, also from Punjab University. He was conferred with the D.Lit degree by IIS University, Jaipur, recipient of Polio Plus Pioneer Award. In 2020, he's nominated as the member of the institute, prestigious institute body of PGI Chandigarh. And he's received several honors and recognitions and awards from Rotary and non-Rotary, non-Rotary organizations. Sir, welcome, and it's our honor to have you over today on the panel here with us today. And I have had the pleasure and honor of working with Mr. Sabu in many organizations involved in the welfare of children and disabilities, such as SORAM in the city of Chandigarh. And he is going to talk about what role Rotary can perform in the handling and management of COVID. We know there are so many challenges at the level of the government to provide services for masses, for people in this crisis. And there is certainly need for inputs from many other sectors like Rotary and others. And we would be very pleased to hear from you, Mr. Sabu, today as to what you think would be the role. I think, considering that we have 3 panelists, each one can talk about something like 10 minutes each. Dr. Meenu, would that be fine? And do we need time for discussion at the end? 10, 15 minutes? Question answers?
I think that will be fine, but it'll be good if they confine to 7 to 8 minutes, because then we can have more questions, and since we're running short of time.
Thank you so very much. Mr. Sabu, over to you, please.
Thank you very much. I have been listening all the doctors, and I'm just wondering what I'm going to be here amongst the specialists and all the doctors. And I am you have very kindly introduced Dr. Malhotra that about my these honorary doctorates, and that is an honorary doctor is of no use actually. So anyway, I was president of Rotary International in 1901-1902, and I would like to mention how we have been in a part of Rotary and have been working together with the doctors. And we speak, when we are talking about the eradication of polio, it was the dream of Rotary in 1978. And it was then, it was the partnership of Rotary with the doctors, WHO, UNICEF. And this is how we have worked together. Rotary International is now about 1.2 million Rotarians all around about 200 countries. And in India, we have about 40,000 clubs and 150,000 deadlock Rotarians. And let me come more in terms of when Dr. Meenu Singh asked me to talk about COVID. I was thinking, and because she is also associated in Rotary, and I was very happy to see that I would be there. And I'm thinking the 2 phases of COVID. And we are not just thinking in terms of the vaccine phase. The first time when it was suddenly we were thought when the the whole country was not prepared. There was a lockdown, and even PGI was not prepared. And I remember that the PGI did not have PPEs, they did not have N95 masks, and we had to, as Rotary, had to come forward to provide all the support system. Not only PGI, but Sector 32, Sector 16, to the administration. And this is how we are together. Also at that time, we knew that there were places like Bapu Dham here and many other places. There was no ration, and we had to provide as Rotary the ration, and even for the doctors who were junior doctors who were staying in PGI, they did not have the food at that time. So these are some of the things that we had to take at that time, and we did. and we became as a partners. And then now I shift to the new situation, the new wave that has come, and the COVID situation, the COVID-19 and the vaccines, what we are going to do. I talked to Dr. Harshvardhan because I have had that association from the time that he was health minister of Delhi, and we started the polio eradication at that time. And I talked to him about what we can do as Rotary because of our uh, record of track record, that can we do something and support with the government of India. And he said that uh, it is little different than what polio was, but you have the strength of the volunteers. And so why don't you think in terms of move to the states and talk with them, which we did. And now we have got uh, this very high-powered task force for COVID-19, where we are going to be working, and we are already working. It is a network where we are working for the awareness. Take, for example, in polio, the minority communities were not, because of the rumors, they did not want to have the polio drops. And the same situation is in the this vaccine. And because there has been in some of the areas, they don't want to take it because they thought that this is a vaccine which is being which is going to damage the brain, and it is the propaganda of the from the West, but they are wanting to do that. So this is where Rotary has come, and the awareness is there, and then we are also taking the from the it is a network where we are going to be, and we are already actually working where there is no proper link where we can get the vaccine to be reached to the slum areas. For example, Saketri, which is not too far. It is a slum area, and they have got about 300 people who deserve to have this vaccine. But they have by now until yesterday they had only 15 who had gone, because they don't want to come to the hospitals. But we have got to keep and get somewhere that we can bring the source to vaccine to them. That is what Rotary that is trying to do, and not only here in Kerala, in Lucknow, in UP, and many places, they have recognized Rotary as an official, this volunteer and non-government organization, NGO, and they are working together. This is how we are going to be doing, and we have already started. And I hope that when we talk about the telemedicine, of course, I have been used of telemedicine in Africa because I have been going on medical missions since 1998 in Africa, and there only there is no telephones or no facilities of communication. So telemedicine works there fantastically. And I know that here it will also work because from PGI to the rural areas, this is how we'll do. And will, in, we are aware and we are available for whatever we can do. That's why I want to thank you for this opportunity of joining you. And I personally feel as a part of PGI. And once again, greetings to Dr. Minu Singh, because she is the one who initiated this Foundation Day celebration. God bless you. Thank you.
Thank you, Mr. Sabu. Thank you very much. I think you've highlighted and mostly as the practical points as to what this stellar and human service Rotary has been providing, has done it in the past, and is also endeavoring to do it now. Apart from providing the basic essentials like medical supplies, PPE kits, and masks, also to look at the humanitarian assistance in the time of crisis, like food, shelter, and that people needed. And of course, considering the breadth of and the expansion of network of Rotarians all over the world, it's so very important and also possible to reach the unreached, the kind of remotest possible and most difficult, areas, to reach them with your volunteer workforce, and who are so committed. And we know about Rotary and their mission in their heart. And of course, creating awareness, taking the vaccine and thing to people rather than making people go to the centers and do it. I mean, these are the basically and very important and significant steps in supplementing the efforts that the government of India is doing, and all of us, the medical fraternity, is trying to do. And Rotary is pitching in and doing a very, very important and complementary service and function. Thank you so very much. Sir, you stand by for the other speakers, and in the end, if there are any questions, we will have that discussion. Now I'll move on to the next speaker, none other than Dr. Vinayak Mohan Prasad. He's a program manager, tobacco control, working with WHO as senior advisor. And at the moment, he's working on Be Healthy, Be Mobile project mission of WHO. He coordinates the national capacity building team for tobacco control. He has been in tobacco control area domain for many, many years now. I've had the opportunity of working with him under the Government of India project, Tobacco Cessation Clinics, started somewhere about 20 years ago in the whole country of India, that we established these tobacco cessation clinics. Dr. Prasad is also a founding member of Be Healthy, Be Mobile team, which is a joint WHO-ITO initiative set up in 2012. And this is looking at advancing the mHealth technologies to address non-communicable diseases. And he is also responsible for India's largest tertiary healthcare scale-up project, telemedicine, and a few other national programs. And prior to joining WHO, he worked with Government of India in various capacities in the Ministry of Health. And he was the Director, Public Health, Tobacco Control Focal Point in the Ministry of Health and Family Welfare in the past. And today he is going to talk about the innovative and new approaches to tackling the situation, the healthcare service, the crisis arising in the COVID pandemic situation. So there are two aspects. One is care of healthcare services for COVID patients, and healthcare services for non-COVID patients during the pandemic. So Dr. Vinayak Prasad, we look forward to listening to you. about the newer and innovative approaches in delivery of healthcare service in COVID. Over to you. Thank you.
Thank you, Dr. Savita, and good to see you after more than 11 years. And thank you, Dr. Menu Singh, for inviting me for this CME. My association with PGI goes back more than 15 years. And I really enjoyed working with a number of colleagues, including Dr. Talwar and Dr. Menu Singh and others, not only to help build the institution, for which we one of PMSSY and all the tertiary care institutions part of my remit, but I still remember that my boss, those who remember, Mr. Deepak Gupta, would remind me almost every week that let's focus on telemedicine. So amongst 19 other things, we would still end up doing something interesting on telemedicine and telehealth. Those are early days, and Dr. Mishra and Dr. Bedi are all here, that we did try and put some of those structures which Sanjay Sood talked about in creating institutional frameworks. And we have reached there, almost there. And COVID's the time when we can actually test the waters and see how far further we can go as a country, which is so skilled in taking forward innovative technology. Especially, we are providing a lot of support to the global world. And sitting in India, sometimes not visible. But sitting here in Geneva, I can see how India's contribution in the IT sector is, especially health infrastructure, is quite interesting. I wanted to talk, and maybe let me share. I wanted to talk a little more broadly than what we normally end up talking in terms of telemedicine, which is clinical care, patient-centered approach, and that is important. And it's, as Dr. Talwar also mentioned, this is the time when you're also seeing how teleconsultation and things have all evolved during COVID, and now it will be the new normal for many parts of the world. A less discussed issue is prevention and promotion related issues when it comes to telemedicine. So the curative parts are well discussed, but these aspects get to be ignored. And while I'll give the example from tobacco, but much of this will apply for other substance abuse disorders or alcohol issues or diabetes prevention management. So there's a whole bunch of things which we can cover using the same principles. And why did I use tobacco? It's not that I'm the global lead for tobacco in WHO, but it is one of the single most preventable form of intervention which you can to save lives. We have 1.3 billion tobacco users in the world, and 8 million people die every year. So it's total number of tobacco attributable deaths globally. It's far in excess of what's happening in COVID. And it is also a key risk factor, and I don't need to remind because all of the doctors in the room, it's the key risk factor to all of the leading causes of death in the world. I mean, cardiovascular diseases, cancer, of course, but then there are a whole bunch of other disorders for which tobacco has been identified to be a key risk factor. And what we have seen, especially in the early days of COVID, was that with the impairment of lung function, it was the tobacco users, especially smokers, were getting into more severe COVID. It's not that tobacco use leads to risk of COVID, but that evidence is not still out there. But at least it's evident that those who are smoking and get into COVID infection, then they have a higher risk. And it's obvious because of the comorbidity issues attached to it. During this time, what we saw, and I'll just give this example, that cessation services, supports to help tobacco users quit, is anyway very weak set of interventions globally. India has done a bit with running with their quitline programs and mobile programs and integrating counseling in a number of states now. They're quite active, these counselors, but less than 30% have access to these services. And during COVID, it's even gone down. So how do we leverage technology? So I want to remind that when we launched this mobile program in 2016 in India, this is one of the early moments for WHO to work with the Indian government. And it was quite an interesting experience because the government of India took the leadership and set up this mobile platform, which allows for text messaging to go across for a period of weeks. In in no time, this initiative got 2 million. And then, of course, in the last couple of years, it hasn't been pushed. So that's a very important lesson, is that how we need to continue to engage with the public and inform them of these services. Otherwise, their utilization comes down. And it's the same story with the Pan-African Telemedicine Network, which has been established decades ago, and the use is limited. So we need to set up programs, and we need to also promote it. The other lesson which we learned was that when we launched this mobile tobacco cessation program in India, which is very functional, it took us 2 years to do it. But when we set up the diabetes program, it took us less than 3 months to do it because the same platform and all the integration can happen very quickly. And the scope to expand the current platform, which India already has, within next 3-4 months, if there is a decision made, we could easily launch and scale up a number of other mobile applications like the mobile physical activity program or the mobile COPD program, the mobile cervical cancer program, the dementia program, and the aging program still under development, but we can launch all of that. And that to me is what we should be looking at in creating the digital infrastructure, and the mobile infrastructure is so crucial to that. And these are some just indicative figures. And based on what India did in 2016, we got a full-scale program launched even in Senegal, Egypt on diabetes. We've launched one in Zambia on cervical cancer screening, and all of these have good outcomes. The return on investment is extremely high. And so again, that's an important lesson to take note of. More recently, during COVID, we've looked into use of artificial intelligence. So the health worker is normally supposed to give brief advice and like 1 to 2 minutes, like ask it and advise the person who's a smoker or tobacco user on guiding him or her into the right direction on advising them to quit. These are basic kind of questions, which is all health workers are trained to deliver. We looked at all the questions which are possible, and then we formed the AI tool. We call it Florence, and she speaks to you. You look at the link which I've shared there. She speaks to you. It's already available in English, French, Spanish, but we'll do in more languages. And it's a very interesting experience we are seeing, and this is very early days. That how can we actually have a basic barefoot doctor kind of digital worker who can give us information? And again, same story. This one can answer more than 200 questions on tobacco, but I can easily get it populated for any of the interventions, because there's no limit to it. This worker can speak on anything. Then what we looked further is WhatsApp and digital solutions, the Facebook free basics and Viber. Now, WHO has this app for COVID, and it's got more than 18 million people who actually use it. And India is one of the highest users. And look at all the WhatsApp for WHO, what's happening in the world, what kind of directions we need to see, what kind of advice. We're just adding, and we've already done it, is that we added a two-way message system in the same app for tobacco. And it's while India does have its mobile cessation program, so we are more robust. But if a country doesn't have the wherewithals to launch a mobile program, the WhatsApp solution works very well. And I think within 10 days of piloting, we were getting more than 3,000 to 4,000 people just downloading and looking at this. It's basically just sending a message to the system, and then the system takes over. It's a very interesting way to scale up the solutions. The other thing which we have done is to launch more and more e-learning interactive courses in WHO's iLearn, and also we're now working through the WHO Academy, the recently established academy, to have an integrated counseling course, not only for tobacco, but for alcohol, physical activity, unhealthy diet, bunched and very interactive training solutions, which I wouldn't say replaces the conventional creating a workshop and bringing all of the health workforce together, but it's a great way to make available workshop for training the health workforce. And this is gain for us. We've seen good traction. Very interestingly, we also launched one on tobacco product regulation, and within 3 months, we had more than 10,000 people using, and half of them were from India, which is quite interesting. As to Indian public health workforce is one of the most excited about use of these tools. So again, we have a great opportunity for putting in place some of these measures for a number of other programs. But what also Dr. Sood mentioned was also a matter of concern, is that less than 40%, 37% of Indians have access to internet. And so that basically means that we need to look for other jugaad innovation, as Dr. Balram Bhargav would have said. And we need to look at different options. I mean, 3-to-1 kind of an interactive voice response, basic phone linked access, looking at making available in Wi-Fi and internet without the cost to it, like the Jangala and other solutions which have been developed for being used in sub-Saharan Africa, talking books which UNICEF launched, and some of these options do exist. And I think India again is very well placed to create some of these innovative solutions to get improved access. These are early days again for this area of work. But when I say early days, it's not that pilots have not happened. It's not that there are not solutions, but how to scale it, how to sustain it. Those are very important questions. The whole mass media campaign and creating workshops, doing events seems to be difficult now. And how do you handle it then? So last year, for example, during World No Tobacco Day, we looked at all of the social media channels, and we got more than 3 billion hits, views, reviews, which is 10 times higher than what I got in 2019. And I think, again, a very important lesson is that we have the ability to scale using social media. So even this year, which is the campaign, which is a longer campaign, not as one-day campaign, we're looking to get more than 100 million of the 700 million people, smokers who want to quit. And the target is, including India, we are already working in 25 countries aggressively to create the ecosystem for quitting. And again, technology is a great enabler. So even during COVID, when systems are broken down, we are able to make headway through different strategies. So thank you for your attention. And I will be here when we have the discussion. Over.
Thank you. Thank you so very much, Dr. Vinayak Prasad. It's very, very enlightening, informative, and apparently, I think what you have presented is the whole plethora of different digital technologies which are being used in different ways to achieve different targets, using tobacco control as a method or strategy, as a case in example, and which can be scaled to any other condition, and primarily looking at health promotion and health prevention of non-communicable diseases. It's a great thing, and very, very challenging, informative, and exciting, actually, that this opens up several opportunities in the minds of everyone, not only the user, the end user who's going to employ these or use it, but also us, the healthcare professionals, as to what is the possible potential and scale at which we can really work. Thank you so much. And then we move on to the third speaker in the panel, that is Shri Anup Kumar Gupta. He is principal consultant. This is E-Vidya Bharati. What is this? I am less familiar with this. This is E-Vidya Bharati and Arogya Bharati.
This is what.
Yes, E-Vidya Bharati and Arogya Bharati Network project. And this is an initiative to offer telemedicine services to Pan-Africa. And Mr. Anup Kumar Gupta, he's a graduate from IIT BHU, executive program in e-governance from Manipal, and contributed to many transformational e-governance initiatives of Government of India, like ease of doing business, Startup India, so Passport e-Migrate, Tele-education project of Ministry of External Affairs for African countries. And so he's primarily from IT background and expertise. And this project that we are talking about, E-Vidya Bharati and Arogya Bharati Network, this is the project of the Ministry of External Affairs. And this endeavors to kind of create telemedicine services pan-Africa. Let's hear from Mr. Gupta what he has to say on this very topic. Mr. Gupta, please.
Good morning, all distinguished members attending this online event. Thank you to Director PGI Chandigarh, Dean PGI Chandigarh, and Professor Meenu and the whole PGI team for providing us opportunity to share details of telemedicine services under E-Vidya Bharati and Arogya Bharati project of Ministry of External Affairs. So let me start with the genesis of the project. The first phase of the project that was called Pan-Africa E-Network project, that was implemented from 2019 to 2017 to offer education and medical services through satellite mode. So communication mode was satellite. So after that, based on the commitment made by Honorable Prime Minister, October 2000, Government of India approved the technological upgradation and extension of the Pan-Africa E-Network project. The project was renamed as E-Vidya Bharati and E-Arogya Bharati Network project, and the duration of the project was 5 years, and the project will be delivered through the internet than the satellite mode in first phase. So the E-Vidya Bharati Arogya Bharati project was formally launched by Honorable Foreign External Minister on 7th October 2019. So in this project, actually, there are two parts. One is E-Vidya Bharati, that is the tele-education project to offer online degree programs of premier Indian universities to African learners. That program is well going on for African countries. And another part is e-Arogya Bharati that deals with the telemedicine part, and this telemedicine has two scope to offer in African countries. That one is teleconsultation from doctor to doctor, and another is continued medical education services to offer medical sessions to the African countries. So this project is basically fully funded by Ministry of External Affairs, which will include the establishment of e-Arogya Bharati platform and making services free of cost for the African doctors, nurses, paramedic staff. So in that, actually, the teleconsultation fees will be directly paid to the Indian hospitals for the project, and for continued medical education services, the scholarship amount will be again given to the Indian hospitals, which will offer the continued medical education session to the African countries. EV Baby project means EV Baby team has spent considerable time to incorporate the learning of first phase, and also we have run trial of telemedicine services with the help of PGI Chandigarh, SGPGI Lucknow, CDAC, and African hospitals. So those learnings are very fruitful for us, and we learned that some of the critical factors affecting the success of the project depends on means identification of medical specialties required in Africa, active engagement of doctors in India and Africa, dealing with geographical time difference between two continents, dealing with language barrier, and the development of customized telemedicine platform for with the functionality required by the users. So, and also for the better coordination between Indian hospital and African hospital, we are receiving continuous nomination from the African lead hospital and the telemedicine coordination from African countries, so that the project could be a smooth implementation and can be run for 5 years without any hiccups. Specifically on CME services, EV Baby team is doing extensive consultation with Indian government and private hospitals to finalize the modalities, and soon we will be signing some agreement with few identified hospital in India with mutual agreed terms. For this CME services, actually, PGI Chandigarh is already offering few CME courses. So recently we have integrated those services with our tele-education portal and offering to the African countries. So finally, the modalities are being worked upon for development of telemedicine portal, which will be launched soon for the African countries. This is from my side.
Okay, thank you very, very much, Mr. Gupta. I think you've introduced to us a very important and a very new kind of initiative of Government of India, Ministry of External Affairs, where in Africa, India is supporting through these technologies education as well as healthcare. To different kind of initiatives, E-Vidya Bharati and Arogya Bharati. Thank you very much. With this, I would like to kind of open this the session for any questions or comments or any participant would like to add, ask, or give any opinion about. I mean, you can address your questions to the individual panelists. Kindly introduce yourself first, and then you can talk about it. Do we have, Dr. Meenu, any way of these questions being listed, like in a chat box? knowing, or
Yes,
will
sir.
they?
We
Yeah.
have on WebEx, we have a chat box.
Yeah.
So they can be posted there, but if anybody likes to speak out, even that will be fine.
Okay.
So far,
Okay.
we don't have a question on the chat box,
Yeah.
but I would just like to ask Sabu sir, because Rotary has a great expanse and working in Africa, and sir has been leading missions to Africa for several years. So how would you foresee the introduction of e-learning platforms from India to those countries, sir?
Is that the question to me?
Yes, Mr. Sabu, please.
Yes, sir.
I could not hear properly. Can you repeat it, please?
Sir, the question is, yes, sir. The question is that...
डॉक्टर मीनू सिंह बोल रहे हैं?
Yes, sir.
Yes, sir. Yes, sir.
आप मास्क निकाल लीजिए ना एक बार. वहाँ तो कोई नहीं है.
Okay, sir.
हाँ.
So, basically, the question is about Africa, and since Rotary has a great expanse in Africa, and you've been leading missions to those countries, how do you see practically these e-learning platforms which are being opened by Ministry of External Affairs to those countries?
We have started having the medical missions from 1998, and by now we have probably covered about 25 countries in Africa. And the only, we find that the most advanced is Rwanda. And there we have seen that there is telemedicine is very effective. And also in Zambia, many of the countries. And we have felt that we cannot just go there and do the surgeries except the cancer or heart surgery we cannot do. Otherwise, we do all the, because all the doctors, I am not a doctor, but we have been having the surgeons and doctors, we have been going about 20 doctors on each of the medical missions. And there we have found that many times we are handicapped because we cannot interact with the language and the doctors from India. So through that, the telemedicine becomes important with the translation from different places. And the telemedicine, what I'm saying is, it's a telecommunication, but medicine comes because many times it is the medical terminology. So this is how we have felt the necessary and how it has worked very well. And as we have heard from the external affairs representative, that this also helps in the connection between India and the countries of Africa.
Thank you very much, sir.
Thank you so much.
Can I ask a question?
Yes, sir. Yes, sir. This is Dr. Sunil Shroff from Funds Foundation.
Yeah. Why is echoing? I just wanted to know if, there is going to be some problem with cross-border
teleconsultation between India and Africa, how are we going to take care of registration of doctors, in those countries?
Please repeat.
Dr. Anup can take up that question. Anup, because they are going to be conducting this telemedicine network there through eSanjeevani. So I think Mr. Anup can take up that question.
समझ में नहीं आ रहा है.
Is there echo?
तेरा जोर से बहुत बताएं.
Was my voice echoing?
There was a little background echo, sir, but now it seems to be
better, yes.
I said,
sir,
that
can I repeat?
Let me disconnect and connect again.
Dr. Shroff wants to know how are we knowing about the registration and empaneling the doctors abroad in Africa?
How do we the registration, which type of doctor they go with us? Is that the question?
Yes. How do we know them? How do we verify and register?
Normally in our Rotary itself, we have the specialists. So we look for of all these surgeons because we don't pay anything to them.
You don't get my question.
The medical missions, honorary total.
Mr. Sahu, you're not getting my question.
Even if they are not Rotarians, they join and they go with us.
Mr. Sahu, you're not getting my question. When you practice in a country, you're required to be registered in that country and have a license to practice. So if you are going to be, let's say, an Indian doctor giving teleconsultation cross-border to an African country like Rwanda or Zambia, then he needs to have some kind of a provisional registration in that country. So how is government of India going to kind of take care of that? Because that is something which is very tricky on cross-border, consultation. Yeah. If it is a medical legal case, you prescribe a medication, something goes wrong, then what happens? So those issues need to be addressed before you go for cross-border, kind of consultation. It's a great project, but there are legal implications which we need to
I fully understand. We have gone through that, the situation, and the host country, they take care of the responsibility about two things: about our doctors and the surgeons can work in that country, so they have to take their own national medical association or whatever it is. They get that. And the other thing is how we get the medicines, because sometimes the medicines are not available there. So we have.
No, we're not talking about that issue, Mr. Sahu. I'm just saying.
If I may interject, sorry, Mr. Sahu. I think Dr. Shroff, let's leave it be, because we will be addressing this issue, and probably the audience would be, set clear about this contentious issue, because possibly he may not be aware of these issues. So let us leave it at that, and we will address it in our panel discussion.
I was actually addressing it to the Ministry of External Affairs, who had brought this more than anything. Anyway,
I hope the rep from the Ministry of External Affairs would extend his presence till the next panel discussion, where a lot of these issues would be discussed. If you have the time and the inclination, please attend the next panel discussion also.
Let me just let me make some observation. Maybe I'm not understanding the question. How do we go to and the host? We find as to where the need is.
And the question, sir, Mr.
Mr. Sahu,
the question is
actually just a moment of
licensing
yes
practice in that country. foreign doctor to practice in that country, they will require a valid license or permission.
Yes.
And what is the way to go about that? That is the question. But
The
I think
license,
that's a very specific question.
yes, the license that is required for them to work in that country. Is that the question? Yes.
Yeah.
Now, that is the responsibility of the host country. That means if it is Nigeria or Zambia or Rwanda, whichever country, it is their responsibility.
Yes, sir.
We have had the problem because they wanted the degree from UK, but now they have recognized that the universities and in the institutions in India, they have been recognized, and they get all the details. They have got all the certificates and everything, and by that they put it at their own national council of medical society or whatever they have, and they get the approval. And only when they get the approval, then we have them.
Thank you so very much. That clarifies. And I think with this, I come to Dr. Meenu Singh. Do we have time for some more questions, or do we need to?
Let us.
Ma'am, there are no questions. Otherwise, I think we will wind up now because we have the next panel waiting.
The next panel ready. So with this, I would like to conclude and thank each of the panelists, Dr. Sabu, Dr. Vinayak Prasad, and Mr. Anup Gupta, for excellent and wonderful informative sir. Okay, and thank you so very much, and thank you, Dr. Meenu Singh, and my colleagues.
Thank you, Dr. Malhotra.
Thank you so much. Thank you. Namaskar. Bye.
Okay.
Thank you very much.
Thank you.
Thank you, ma'am. Thank you so much, and thank you all the participants, and especially to Dr. Shri Sabu, our PRIP, and also Vinayak Prasad, Dr. Vinayak Prasad, which we had been working for long years, and of course Dr. Savita Malhotra and Dr. Anup Kumar. It was so very nice to come in and tell us about the e-Arogya Bharati project. Thank you very much. So next we go to the next panel, and this panel is going to be chaired by the President of Telemedicine Society of India, Colonel Dr. Ashwini Goyal. And he is currently the president of Telemedicine Society of India and an accredited external assessor and senior consultant of quality assurance and the quality improvement, technical advisor automation, guest faculty and external examiner for several universities. He's a national task force member for Swasth Bharat and has been very, very active in getting the telemedicine practice guidelines being released by the government of India. So now the floor is yours, sir. Please carry on with the rest of the speakers. Thank you so much.
Thank you, Dr. Meenu Singh, for those kind and gracious description of me and my activities. At the outset, I wish to thank the organizers of the Foundation Day of the Telemedicine Department of Postgraduate Institute of Medical Education Research, Chandigarh, for inviting me to chair the session. And my heartiest congratulations to the organizers of the Foundation Day of the Telemedicine Department of PGI Chandigarh. And as you mentioned earlier also, Dr. Meenu Singh, that it also happens to be the e-Sanjeevani Day, possibly. Maybe it was started. So to the people connected with e-Sanjeevani at CDAC as well. As you know, in fact, there are many members of the Telemedicine Society of India in this exalted audience. We at the TSI have been working for the past 20 years to get the government to establish a regulatory framework for the practice of telemedicine in India. It has now been a year now since we helped to draft the telemedicine practice guidelines at the behest of the then Chairman, Medical Council of India and member Niti Aayog. Our efforts resulted in the release of the telemedicine practice guidelines on the 25th of March last year, which thereby formalized the regulatory framework for practice of telemedicine in India. The pandemic, due to its peculiar circumstances, provided the necessary fillip to promote the cause of telemedicine practice. That was, of course, a serendipitous offshoot of the pandemic. The affordability and accessibility of telemedicine has made it an acceptable mode to connect with the physician. Amongst the physicians and the care seekers with the caregivers and caregivers with the care seekers, the byway process. Consumers feel secured with the formalization of a legal structure and are able to rely on this mode of practice with equal reliance and fervor as extended to the practice in the brick and mortar world. The TSI has taken up the mandate of training the registered medical practitioners in the practice of telehealth under the ambit of the telemedicine practice guidelines in a very big way. As you all know, it is mandated within the body, within the statutes of the telemedicine practice guidelines, that all those who profess to practice telehealth in India should be trained and certified in the practice of telehealth within 3 years of issuance of the telemedicine practice guidelines. Amidst this backdrop, the registered medical practitioners have had multiple experiences and should be able to speak better. Telemedicine practice guidelines were brought out in a hurry. The general impression being that they are very restrictive in nature. More drugs could be included. There is a need for training for caregivers and care seekers, as well as issues of privacy and security of personal data. Hence, rightly so, the agenda for the discussion is telemedicine practice guidelines, effectiveness, and issues of last 1 year. So we have a very distinguished panel of speakers in this panel discussion. The first speaker is Dr. Sunil Shroff, who is the senior consultant urologist and kidney transplant surgeon at the Madras Medical Mission in Chennai. He is also the president of the Nephrology, Urology and Transplantation Society of SARC and the advisory board member as representative of Mohan Foundation. He was one of the first to publish his experiences with the application of holmium laser in urology, especially kidney stones, from the Institute of Urology. He started the kidney transplant program at SRMC in 1995 and implemented the deceased donation transplantation program. He was the leader and one of the first 3 hospitals in India to have established such a program. He performed the first kidney transplantation on an HIV positive patient in India. The first successful transplant of kidneys from cobra-bitten brain death victims, and he has done 4 such kidney transplantations. He is currently the president of the Tamil Nadu chapter of TSI, and he is in charge of the training wing of Telemedicine Society of India. So, Dr. Shroff, what I'd like to ask you is to lead with your thoughts about what has been the growth and opportunities of telehealth in last 1 year, and what do you think are the barriers to the growth of telehealth in India? Dr. Shroff. Sir, you are muted.
Sorry, so sorry. Thank you very much for the opportunity, Dr. Meenu Singh, Dr. Goyal, and great pleasure to be here on the Foundation Day of telemedicine department. I would we have all seen that during the COVID pandemic, telehealth has shown a great upward growth, and one of the champions of this has also been the e-Sanjeevani, which is housed in Chandigarh. I see that later on we have a speaker from e-Sanjeevani, Dr. Sanjay Sood, coming on. So if I may be allowed, I can share a few slides, or I can just speak like that, whatever is possible. Can I share my slides? Is it possible?
Please go ahead, sir.
Yeah,
I think the system permits that.
Yeah, sure. Am I audible and can you see my slides?
Yes, yes.
Yeah. So we we had this Telemedicine last year, and we released a report by TSI and the Practo on the growth of telehealth in India. And this had more than almost 1 million consultation looking at that. What we found was in this report that doctors were mostly from tier 1 and 2 cities, and patients were mostly from tier 2 or 3 cities, or even smaller towns. There was a spurt of consultation from rural areas. First time women consulting showed increase from the previous year, almost by 60%. And rise was also there in people above 50 years who are not so, digital literate kind of people. They showed a rise as well. So this was a report we released during Telemedicine, which we held last year, as you saw. And this is a report which I released. What we also saw was that the topics discussed for telehealth consultation, the conditions which came, differed from the different age groups. In the younger age group from 21 to 30 years, it was usually things like skin problems, fever, anxiety, redness of eyes, or the PCODs in women. Among 31 to 40, we saw more of things like hair fall, acidity, pregnancy, toothache, sexual problem, vaccination for children. And then in 41 to 50, it was more about chest pain, weight loss, lower back, backache, menopause, depression. And 51 to 60, it was more breathing problems, hearing loss, skin allergies, and so on. And over 60, it was related to panic attacks, heart problems, respiratory problems. What we also saw was that there were a lot of non-metro cities which were showing growth, and a lot of growth in mental health queries, last year. And this was obviously understandable with all the anxiety. There are less than 10% overseas consultation, and these are mostly for specialties or second opinions or follow-ups. So there are huge opportunities, and telehealth consultation is here to stay. The new normal is today a hybrid form of medical practice where you have both in-person consultation for especially emergency situation or situations where you need to see a doctor, and teleconsultation where it is possible. The government of India also is giving a great push to telehealth. In its, with the Ayushman Bharat trying to cover almost 400 million people through the wellness centers and EAPSCs and eSanjeevani. So these are, I would say, the opportunities for telehealth, and this is the growth of telehealth, Dr. Goyal, and we can talk the barriers as we move forward. Thank you. I can stop sharing my screen.
Thank you, Dr. Shroff. That was very lucid indeed. I would now like to call upon Dr. Murthy Remila as a second speaker. Dr. Murthy Remila is a diehard scientist and technologist. He is in the reverse chronological order. He was deputy head of IRS and ISS CMO, ISRO Satellite Center. Then he was the chair of the, he has also been the chair of the Telemedicine 2018 organizing committee. He was deputy project director, ExpoSat Satellite Project, ISAC. He headed the supply chain management at ISRO Satellite Center, Bangalore, and is currently heading the project management human space flight group Gaganyaan program of India, at the ISRO. And as far as TSI is concerned, he has been, he's a life member of TSI, one of the pillars of the society, and he's currently the honorary secretary of Telemedicine Society of India. Dr. Murthy Remila, I would like to ask you, what are your views on the pertinent issues with regard to the telemedicine practice guidelines? How do you feel it can be made more relevant in light of the COVID pandemic? Over to you, Dr. Remila.
Yeah. Thank you, Dr. Meenu Singh, and my co-panelists and all the audience. the interactions with many of the organizations and the individuals who are the life members of TSI or who want to become life members of TSI. In the context of the practical telemedicine practice guidelines is the timeline defined in the practice guidelines is those who want to practice telemedicine have to become certified within a period of 3 years. Now, and they are waiting for the course curriculum and the mode of the examination and how to get it enrolled or how to complete the course and study the course. That is one of the observations from the interactions with the people. And the good part of the telemedicine practice guidelines is it has not specified or insisted on particular hardware or software, but they seem to be asking or looking for some minimum standards or some minimum framework for any software or hardware to have, because each and everybody without knowledge, with or without meeting the requirements or meeting the guidelines, they are coming out with a plethora of hardware and software and solutions and apps. So though it is not seen like requiring a mandatory certificate, but a minimum framework for these hardware and software are being sought by the individuals whom I am interacting with. And the third dimension is how about adding an individual or a one man clinics into the telemedicine practice in a bigger network. Of course, big hospitals and big networks, they have their connections and MOUs, and many hospitals and doctors are empaneled. But how do the individual doctors, he may be a specialist or he may be a general practitioner, how do they come on board? They are bigger telemedicine network of India. These are the three issues which I came across in my interactions over the last 1 year. We will discuss further. You are muted.
Yeah, thank you, Dr. Amila. That was very pertinent, the issues that you brought out. And of course, something very relevant is the integrating the individual registered medical practitioners into a bigger network, or shall we say a network of networks, where I think India, the telehealth scenario in India is fast progressing towards. I call upon our third distinguished speaker, Ms. Bagmishika Puhan, who is an associate law partner at the TMT Law Practice. She is a member of the Executive Committee of the Telemedicine Society of India, member of the Ethics Committee Academic of Mohan Foundation, as well as the Indian Society for Clinical Research. She has a number of publications on healthcare and privacy laws across medical and legal journals, and her forte is privacy and security legal implications. A point to be noted is that she has a major role in drafting the telemedicine practice guidelines at behest of the member Niti Aayog and the erstwhile chairman of the MCI. Ms. Puhan, I would like to ask you to begin with, what are the laws applicable to physicians who practice telemedicine? The laws applicable to physicians who practice telemedicine.
Dr. Goel. So, in addition to the laws that generally apply to any registered medical practitioner in the country, like the Indian Medical Council Act, certain provisions of the Indian Medical Council Act, because it's still applicable, it has not been entirely repealed. So, the provisions which are continuing to apply onto the registered medical practitioners in terms of the medical ethics that they have to follow, especially with respect to the Code of Medical Ethics of 2002 and any other clinical specialty protocols that a registered medical practitioner is expected to follow and adhere to, continues to prevail over the physicians. Additionally, the National Medical Commission Act and the provisions, especially when it comes to dealing with information and technology systems for the purposes of rendering a telemedicine consult by means of ICT, makes the RMPs also subject to the provisions of the Information and Technology Act, the Consumer Protection Laws, and any other such data privacy and security legislations which is already in place or which is supposed to come, to be notified subsequently. The reason why I'm saying that it is essential to be already wary of the provisions which may be notified under the privacy law is because it's a golden standard across the globe right now. And because a lot of doctors that I have seen in my experience in working with doctors, they're already conversant with HIPAA. It becomes easier for them to adopt or probably emulate certain provisions from there and already inculcate that in their existing practice to ensure tomorrow when there is a new law which comes in place, there is no violation or there is no non-compliance to that effect. So in that sense, to quickly surmise, it is the Indian Medical Council Act, the National Medical Commission Act, the IT laws, and the Consumer Protection Law, which applies to the physicians in general for the practice of telemedicine.
Thank you, Balbishika. That gives us a perspective on the laws relevant to and pertinent to the practice of telehealth in India, and which I believe the practitioners should be aware of. The TSI is in the process of training the registered medical practitioners on all such aspects, more of which would be dealt with by Dr. Shroff in the course of the panel discussion. Dr. Shroff, we were discussing, you mentioned about more about the barriers to the growth of telehealth in India. I would like you to revisit this issue. And also, I would like you to touch upon the role of the Telemedicine Society of India in creating the right ecosystem in the country for telehealth.
Thank you again, Dr. Goyal. I think one of the biggest barriers today we have is the digital illiteracy among medical professionals. Although the younger generation is better adapted compared to the older generation, but there's a huge digital illiteracy among the doctors on how to use telehealth as a form of practice. And that's, I think, the first barrier which we need to think about and need to address it. And here I think the Telemedicine Society of India is playing a very big role because it is a society with a platform where we have doctors, technocrats, and other healthcare professionals. And we are rightly positioned to take care of the digital illiteracy, which is at the moment barrier, one of the biggest barrier. The other barrier, which I think also is, the current telemedicine practice guideline lacks the list of medication, especially for specialties. It leaves it very open-ended. And it leaves the doctor to interpretation. It leads a RMP, the registered medical practitioners, to their own conclusion. And that is not very comfortable to doctors. Even in the trainings which we was conducted by the Telemedicine Society of India, almost 60 odd training programs which we did, the commonest question used to be on this: what can I prescribe and what I can't prescribe? Although the telemedicine practice guidelines has a term called etc., which makes it a larger kind of this one, but it doesn't give them the comfort. So those needs to be definitely addressed. Then we need to also have standards, audits, oversight committees to monitor for safe and ethical practice of telehealth. That's again very, very important. And this is what is going to protect the doctors. What has happened is where we have had an over dependence on private healthcare as well. And over the years, this has created some degree of trust deficit and made the society more kind of litigious, They tend to file in the consumer court things more often than they should. So medical professionals are not comfortable with the medical legal implications of the telemedicine practice guidelines for that very reason. They don't have a comfort level. And that is because of that, the Indian Medical Association, which is the largest medical association in the country today with more than 3.5 or 4 lakh doctors, has felt that the current guidelines do not protect the doctors enough. So we need to address these lacunae in the telemedicine practice guidelines. And as Telemedicine Society of India, we need to play a very pivotal role towards addressing this. I can also tell you that the e-pharmacy bill has been in the parliament for the last 3 years, not moving. And we're talking about e-prescriptions in the telemedicine practice guidelines. So we need to look at that and make sure that some kind of provision is provided that so that the e-prescription format, which is also there in the guidelines for that matter, can be applied properly in practice. And then there is, of course, problem of, as Bagmi will probably elaborate on data protection. The Data Protection Act, which is almost getting passed, is again being sent back to the Parliament for reconsideration and looking at the various clauses. That needs to pass as well, because we need to have one of the most important things in the Data Protection Act of Government of India is healthcare. The privacy and the confidentiality of the patients, and that needs to be addressed, which has not been addressed. And we also feel that the consent process, although there is a consent process for taking teleconsultation, but there is no mandate for collection of consent for processing, storage, or transfer of information. It is not there in the bill. And that needs to be addressed again, perhaps in the telemedicine practice guidelines version 2. How are we going to take care of that? So there are a lot of these lacunas which needs to be addressed, and we need to sit down on the drawing board right now and take care of these lacunae and come out with a draft model of telemedicine practice guideline version 2. One other thing which I forgot to mention is also standard of care. Now, in telemedicine practice guidelines, they talk about standard of care, but standard of care is not been defined. What do you mean by standard of care? Because standard of care refers to provision of service in a manner which is consistent with care as another professional with similar training and experience faced with a similar care situation could provide. This is the standard of care definition. Whereas in our guidelines, it just says standard of care and it's not been defined. It says the RMP shall uphold the same standard of care as in face-to-face or in-person consultation, but within intrinsic limits of telemedicine. So this is again very open-ended. So all these issues need to be addressed so that practitioners feel safe, and we can take this telehealth consultation to another level in India and take care of what we're talking about, remote consultations, those EPHCs, where you may not even have a doctor there in the PSCs, where you may have technician managing those EPHCs, those wellness centers. So if we really want to take telehealth to the most unreached regions of the country, we really need to get our clarity on these kind of points. Thank you.
Thank you, Dr. Shroff. Those are very pertinent, and in fact, there is more like more of a roadmap, which is right there in front of us at the Telemedicine Society of India. And I would like to inform this August Assembly of the organizers as well as the audience of this seminar that we at TSI are quite abreast of the situation, and Dr. Shroff himself is heading our training wing of the Telemedicine Society of India, and many of those activities are slated on our plate for the very near future. We are trying to crystallize our thought processes and efforts towards that end. In that light, I would like to ask Dr. Moti Ramila, as he is the secretary of the society also, and integrated into much of these affairs. So, Dr. Ramila, what is your opinion about most of the things that have been mentioned by Dr. Shroff, with particular reference to the training and research activities to be carried out by the Telemedicine Society of India by way of educating the masses, both the caregivers as well as the care seekers, because you see, telehealth involves a lot of technology, which possibly may not be within the comprehension of much of our masses, especially in the hinterland and the rural areas. So we are now, as you very well know, as a secretary of the society, that many of those programs are very much on the within the ambit of the future, very near future activities of TSI. Your thoughts on that, please.
Yeah. Before I answer, I would like to differ with you that the technology or the hinterland, the people in the villages are away from technology. No, they are very well, maybe if I understood that way, they are very well using WhatsApp, Facebook, video calls, and chats and everything. And last week only.
Let me clarify just for a moment so that the discussion is more fruitful. What I mean is that many of the people in the hinterland are not aware that these healthcare activities, these healthcare solutions are available to them by way of technology.
Yeah, I'm coming.
Yeah.
And incidentally, and totally matching to this scenario, last week only I came across some company who are spreading their wings of telehealth in villages through micro and microfinancing agencies or entities. What they have done, they have installed their software on a tab, not in a clinic or in a CSC or a DSC of the Ministry of Health or Ministry of IT or ISRO center. Nothing. They have they have put up a tab with a simple software microfinancing company, microfinancing entity, what you can call, in the villages where all the finance customers attracted to this platform. They simply connect. There is one paramedic there, and who connects and conducts the session, and they log on and give the minimum preliminary consultation with the specialist on the other end. That empanelment of the doctors and installation of the software is taken care by this company. So that I felt is an innovative way of penetration, because all the traditional people, TSI, ISRO, Ministry of Information Technology, we have been talking, but still all said and done it is not reaching the masses at the grassroots level. But these kind of innovative solutions and path breaking ideas will have a long term sustenance and success in reaching the telemedicine to the really deserving rural masses. As I said, I repeat, they are all well aware, and otherwise also there is one paramedic or a simple technician who is conducting the session. Now coming to the training session, yes, we TSI exactly from the launch of the practice guidelines has conducted many successful programs, but still there are some people who are not aware of the telemedicine or not aware of the telemedicine practice guidelines. So we have to continue that foundation course. But then again, since just 24 hours back, yesterday only we have received one request for a medicine for a pediatric practice. So like that, now we have to branch out to medicine course with foundation course about telemedicine practice guidelines to a degree, which is varying based on the audience, and one third level, which is telemedicine do's and don'ts and the practice real scenario for different specialities like cardiology, ophthalmology, where we have got very number of people, but dermatology and this pediatrician pediatrics, somehow we have very less exposure, at least to my knowledge, in TSI. So we have to develop these courses into the specialty aspects.
Thank you, Dr. Ramila, for bringing out that very pertinent point about developing the telemedicine and telehealth modules for the clinical disciplines. I would like to inform the audience that this has been a continuous topic of discussion between the training team and myself, and we are well on to developing these kind of modules. Some of the modules are already available, and they are just waiting to be launched. We are in discussions with a number of clinical societies like the Cardiology Society of India, the society involved with the diabetes, the dermatology, the psychiatry, and there are a number of things that I would request Dr. Shroff at a little later juncture to apprise you on the training activities which are pertinent to these clinical disciplines. However, at the moment, I would like to ask Bhagvishika regarding this very contentious issue about the implications of the practice of telemedicine on privacy and confidentiality, because the privacy and security of personal data pertaining to the patients and the caregivers as well as care seekers is a burning topic, especially so in light of the recent developments where there are a number of articles in the newspaper regarding major leaks of data security in MNCs and government organizations and what have you. So, Bhagmishka, a little bit upon that.
Dr. Goel. So the telemedicine practice guidelines have given basic guidance with respect to the practice of telemedicine and the framework which governs it all. However, when it comes to privacy and confidentiality as a concept or as a responsibility, it is not outlined specifically within the TPG, and it is beyond the TPG actually, because there's a specific exclusion where the TPG makes a disclosure or a disclaimer that this does not apply to the standards which are prescribed for the softwares and hardware which is being used for the purposes of a telemedicine consult. Having said that, the IT laws and the data privacy laws are the ones which typically impact the journey of the flow of personal and sensitive personal data within the telemedicine ecosystem. So within the privacy law, it is a requirement that it's a mandatory requirement that due notice is given to the end user and consent is received from that end user, from the person to whom such data belongs to, before we proceed with the telemedicine consult and we go ahead and seek information about from the patient. However, the TPG says that there is an inherent consent or there's an implied consent when a patient is initiating a telemedicine consult. Now, that consent is a separate concept altogether because that is dealing or that is restricted to the consent which is necessary for the purposes of initiating a telemedicine consult. That has nothing to do with the exchange of data between the patient and the RMP per se. Also, because Dr. Shroff mentioned that there is a apprehension, there exists apprehension in the minds of the physicians who have to adopt the practice of telemedicine, and they're not sure about how TPG deals in terms of extending a protective arm to them. In that sense, TPG actually makes it very clear, gives a layer of defense to the RMPs, where it says that, whenever there is any breach of confidentiality, which can be attributed solely to technical platform or any technical glitches, then in that scenario, the RMP has a necessary defense to express in a court of law that this was not attributed to their conduct. However, in the event where there is any deficiency on the part of the RMP or where the RMP was at fault in maintaining or a protocol or has actually violated a particular protocol which has been prescribed within the TPG, then this layer of defense goes away. So while the TPG is not entirely secure, because to be very honest, it is not the domain of the Ministry of Healthcare or the domain of the medicine healthcare regulators to come out with the IT and privacy laws. Therefore, a lot of deference has to be given to the personal data protection bill as and when it becomes notified. In absence of the same, there, however, is a layer of defense which can be relied upon by an RMP for the purposes of relying upon or to seek protection under these laws.
Thank you, Bhagmishika. That was a very neat summary of the privacy and security issues and the dichotomy between the Ministry of Health and Family Welfare and the Ministry of IT as far as the privacy and security issues are concerned, and the PDP bill is also there. To wrap up, Dr. Shroff, I would like to request you to enlighten us about with reference to Dr. Ramila's comment about the clinical specialties and the training on telemedicine practice guidelines and telehealth for that matter. If you could enlighten us about the activities which we have planned for the Telemedicine Society of India to undertake in the very near future. You're muted, sir. Muted. Kindly unmute yourself.
Yes, it just gets muted automatically when you don't speak. Sorry, and you don't realize it. So, as Dr. Murthy has raised a very pertinent question, and I think it's this. What I would say is that in TSI we need to have a full-time, your education unit, an academic unit, which is full-time, which has employment of people who will be there doing it, because at the moment, most of us do these things pro bono, but this requires a full-time effort. And that is what I'm requesting TSI to try and take a decision of how to, do the training and research in telehealth in India as a full-time activity. And for that, what is required and what kind of resources are required. In the last Telemedicine, we had decided that whatever funds come from, let's say, Telemedicine 2020, we could use it in the, our training area. But that's not going to be enough, because it requires, at least 2 or 3 people. It requires a platform, and it requires TSI to run it almost every week, one training session for someone. We did it, in the enthusiasm when the COVID happened, and we trained as many doctors as we could, but to keep it going, we need a full-time kind of academy. We are working on the specialties as well. In fact, we have written a few proposals to a few corporates to help us with the CSR funding, because really to keep it going, we will need that kind of backup where, people from technology, people who are going to create content, people who are going to do marketing, people who are going to run it will be required to be placed and housed and being given salaries. And that requires, some budgeting. We have not stopped despite all this, constraints. In fact, even last week, Dr. Murthy brought about pediatrics. I was speaking to Dr. Ratta about doing a telehealth for pediatrics. I think I have written to Dr. Meenu Singh about that we need to have a few specialties. We identified 11 specialties where we need telehealth training in specialties, which includes pediatrics, which includes diabetes, which includes cardiology, neurology, and so on. And we are already having expert in, people with, when we did Telemedicine, if you had noticed that we had actually already done the groundwork, and that lot of parallel sessions with a lot of specialties with this very thing in mind, including one parallel session on security issues, where we, sorry, not parallel, we did a CME on that. How we did a 1.5 hours, session on that. So we have already laid the ground in Telemedicine 2020, and we have brought the subject matter experts. From here onwards, we need to enlarge that and give it a formal structure into training. So the ground has already been laid, Dr. Murthy and Dr. Goyal. We just need to structure it and give it a shape, and we need to take some decisions in our executive committee and with TSI that yes, we are going to sail this ship, and this ship will keep sailing, and whatever resources required, we should be able to push into this. This is my answer to that.
Thank you, Dr. Shroff. I assure you that the Executive Committee of Telemedicine Society of India, with its forward-looking ethos, would very soon come up with concrete decisions on formalizing and concretizing the training activities, which actually are the synchronon of the Telemedicine Society of India. That is the core competence, and that is what the Telemedicine Society of India exists for. The training, research, and promotion of innovations and entrepreneurial activities as far as telehealth in India is concerned.
I just want to add one more point, Dr. Goyal, before I conclude. I would like to say that at our foundation, at Mon Foundation, where we kind of, promote organ donation, we already I have experience with running online courses for the last 6 years. And, that these courses have had huge impact in the country, and not only in the country, but today we are getting people who are taking the courses from internationally from many countries. At least 15 countries, we have students coming regularly to take courses. So there is an opportunity here that these courses will not only apply for India, but once we put it online, these courses will attract audience internationally also. I can tell that because these courses will be reasonably cheap to take, unlike some of the courses from abroad, which are very expensive to take on telehealth. So we have an opportunity here, with our opportunity to make a difference in this ecosystem.
Thank you. Thank you for apprising the audience regarding this aspect, Dr. Shroff. And of course, as far as the reasonable cost is concerned, I'm sure there is a world of a difference between what we can offer to the people seeking training and information on telehealth as compared to some of the other international societies like the American Telemedicine Association and the European Telehealth Association for that matter. ATA is prohibitively expensive. And so these are our plans to offer these kind of information and training on a very reasonable and subsidized cost. As Dr. Shroff informed, we are in talks with certain corporate houses to fund these activities on a under the ambit of the CSR. If there are any questions from the audience, we would like to field those questions. This is a very new and a challenging technology that has come up in India, and I'm sure a lot of people will be curious to know a little more about telehealth in India.
Yes, actually, there are no questions in the chat box, but actually, we are also running quite late, about 20-25 minutes now. So if we can wind up, because we have the next session.
Madam, I think we managed to wrap up our session within much within the time, and I think we made up a little bit on the on the delay.
That was really, yes, you really made up on the time. Yeah, that's right. Yeah.
So,
Can I take just
it's
a half a
actually a
minute?
lag.
Yeah.
Yeah. Sure, sir.
Can I take just half a minute?
Yeah, please go ahead.
Yeah.
Yes, yes,
regarding the training and the viability, etc. In addition to the looking for sponsors, though we will discuss within TSA in detail, looking for association with this MCI or getting some kind of stamp from them that we are authorized trainers, etc., will give more impetus to the training given by us, and it will attract more people. That's all. We'll discuss internally.
Okay. Yeah.
No, Dr. Goyal, you are muted.
Yeah, that's a very pertinent thing. That's a given, of course. We can't do anything without the permission of the MCI. And now the National Medical Commission, MCI is no more. Mr. Bedi, you wanted to ask something?
Yeah, you see, a small point, because we are running short of time. I think, telemedicine practice guidelines, are they in line with the National Digital Health Mission? See, I will cite one small example. Telemedicine practice guidelines, they do not emphasize on interoperability and standards, whereas National Digital Health Mission has a major emphasis on interoperability and EHR standards. Just whether we like to incorporate in the revised this thing, a part of it, like other technology, like artificial based intelligence based system, whether they were also not accepted in telemedicine practice guideline. I mean, about technologies, when we devise it, just this is a point, which I want to make.
Let me clarify, Mr. Bedi. The thing is that the version 1 of the telemedicine practice guidelines, as you are very well aware, they were brought out in a hurry. And much of these things, which are there are 5 things which have been left out as exceptions, and of that, robotic surgery and AI is one of them. So are the standards. And as you know very well, I mean, you are a member of that committee yourself, where I'm chairing the subcommittee on standards for telehealth under the Bureau of Indian Standards. See, in the body of the telemedicine practice guidelines version 1, it is already mandated. It has been specifically mentioned that there would be a review. The telemedicine practice guidelines would be revisited for review. And as we all know, a year has already gone by, and it is high time that we collated all the information available, all the points available, and presented to the National Medical Commission a sort of a white paper on reviewing the telemedicine practice guidelines. There is a groundswell of opinion as far as these issues are concerned, and I'm sure they would be highly receptive as far as the review is concerned. If there is nothing else, then I think I would hand over back to Dr. Meenu Singh in light of the entire program running a bit late. Over to you, Dr. Meenu Singh.
Thank you very much, sir, for chairing this extremely important session. And thank you all the speakers, Dr. Shroff, Dr. Murthy, and Bhagwanshika Puhan for participating and taking up all the questions. We will now move on to the next session, and I'll request Dr. Amit Kumar to introduce the chairpersons.
Now I would like to invite Dr. S.K. Mishra and Dr. Biman Sekia for chairing the next session. Dr. S.K. Mishra is Professor and Head, Department of Endocrine Surgery, SGPGI Lucknow, and is also Dean of SGPGI Lucknow. He is in charge of School of Telemedicine and Biomedical Informatics. He established first academic Department of Endocrine Surgery in the year 1989 and first School of Telemedicine and Biomedical Informatics in India in 2006 in SGPGI Lucknow. He is Fellow of National Academy of Science and American College of Surgeons. He has over 250 publications in his credit and is consultant in e-health for WHO, WB and ITU. He is past president of Indian Association of Endocrine Surgeon and Telemedicine Society of India. We have second chair is Dr. Biman Sekia. He is professor, Department of Immunopathology, PGI Chandigarh. He has done MBBS from Assam Medical College in 1992 and MD from PGI Chandigarh in year 1997. His work, he is mainly focused on transplant immunology, primary immunodeficiency disorders, autoimmunity, and telemedicine. He is also nodal officer for PGI Punjab Telemedicine Project. So I would like to invite both the chairs and introduce the speaker for this session.
I would just like to inform the House that Professor Mishra is also an alumnus of PGI, and we have always been receiving very wise counsels from him.
Okay, thank you, the organizers. Thank you, Dr. Minu Singh, for inviting me to chair this session along with Biman. So I join with Dr. Biman Saikia to welcoming all the participants of this session, as well as all the faculty and other delegates who have been joining through online. I just want to check my audio. Is it okay? Someone say yes or no? Is I audible to all of you?
Yes, sir, it is. Yeah,
Okay.
yes, sir. Yes, sir.
So I take the pleasure, along with my co-chair, Professor Biman Saikia, to welcome Professor Ravi Kumar Chitoria. And Ravi has been associated with us from the beginning of when we started our National Medical College Network project. That's the time when I came to know about him. He's basically a plastic surgeon, and he's heading the department there, and he has been looking after several responsibility in JIPMER Pondicherry. And he has introduced many new unique systems of telemedicine there, and starting from the streaming, and besides the routine consultation, etc., that we have been doing here. So he has been doing there. He also, when spearheading the BIMSTEC project, where the Bangladesh, Myanmar, all these things have been connected under administrational affairs. So the beauty of Chitoria is he is a very quick learner, and I have observed him. Something he sees and he just goes and practice, and he's very enthusiastic and passionate. So that is the most important thing that has driven telemedicine in JIPMER as well as in the southern part of India, and he has been responsible for mentoring medical colleges in the southern part to adopt telemedicine and also to join the NNCN project. So with that introduction, I invite Dr. Ravi Chitoria to give his presentation.
Is my screen being shared? Is it visible?
Yes, it is visible.
Yes, sir.
Go ahead.
Respected chairpersons, all the participants online, very good afternoon. And at the outset, on the behalf of Director JIPMER and Telemedicine Center RRC JIPMER Pondicherry, at the outset, I would like to thank Professor Dr. Minu Singh, who gave this opportunity to us to share a JIPMER experience, how we managed and did the application of telemedicine for COVID patients and otherwise. So with this, I would like to first highlight what were the problems, and we all know this. So there was a wide gap actually, wide gap with the workers, with the patient, with the student, with the faculty, with the colleges. A lot of problems were there. And then how we managed, I would like to divide it into what we did for patients, students, administration, and continuing the academics, including research and publication. It was very easy for us to start with this first. Reason being, telemedicine clinic was already there, were there, and it is always easy to follow at least those patients which we have seen it. So moment patient comes, we provide the stamp and the telemedicine number through which we identify him online. And the respective doctor records the patient detail. And on a particular day and time,
Yeah. Can you tell me your telemedicine number, which is written on the front sheet of your case sheet? It is 729. You are from Viruddhachalam, Tamil Nadu, correct? Yeah. You have some problem in your leg. I'll check your photograph.
These are the records which we always capture the first time patient comes.
Patient. I'm seeing your one. Can you tell me what is the status now? Are you having any swelling over the leg? Everything is fine? Okay, thank you.
Sometimes we are calling the patient. Instead of patient calling, we also call them to see their condition.
Patient every condition operation Good morning, Ramchandra. This is Jitma plastic surgery doctor here. You called us on video call. And you told us your hospital ID, from which we got that you have operated on your right hand. So where are you calling from, Ramchandra? Oh, where is your home? Okay. How many kilometers from Pondicherry? 300 kilometers. Okay, okay. So why you are not able to come to hospital? Oh, because of the COVID-19 pandemic, you are not able to come. Okay, okay. You are operated by your right hand. So can you show me how it is moving now? Can you move your hand? Okay, okay. And any pain is there in the hand? Okay, okay. Any other problem you are having? No problem. Okay, okay. So Ramchandra, your hand looks good to me. There is no swelling apparent on that, and there is no other problem. So you continue the physiotherapy at your local physiotherapist doctor. Okay. And after 1 week, you can call us back on the same video call so that we can see the progress of your condition. Okay. Thank you, Ram.
And then the problem is for those patients actually who want to come, and those are positive and otherwise. For that, we developed the dedicated COVID block with the dedicated medical record department, where dedicatedly all our telemedicine operators were sitting and engage with the calls with the all the patients. This number we have advertised in the newspaper, cable channels, on the website. So any patient can call us. And then those patients who are admitted with us, maintaining the distance, we have developed our own kiosk using the old trolley, putting a laptop with the IV stand, cable and the camera with a printer down. And with this, we can always remotely talk to the patients online. Okay. And then we were using a PTZ camera so that the consultant can talk to the sister anytime in the ward, and that application is downloaded in the doctor's mobile without entering in the ICU, maintaining the distance or from the home. Monitoring also was possible. It's being monitored. And the medicines were distributed by the nurse, and if any doubt is there, he can ask. We made a tele drug distribution trolley. We allowed the attendant to talk to the patient. Attendant can always, otherwise they feel and maintaining the social distance. We kept a tablet on the trolley and one tablet inside the ICU.
Betheria, can you just speed up, please, with the shortage of time?
And regarding the classes, online classes or webinar or conferences, each department has been made a seminar into telemedicine center where the classes or the teaching can be conducted without affecting the students' career. Or this class is happening between KGMC, Lucknow, and plastic surgery. Then we have a drone which was used for monitoring remotely. This is a nano drone. It's the size of the palm. So it doesn't need a licensing from DGCA. And it can capture all the vitals of the patient, condition of the patient. It can record and it can be viewed on the mobile. And this is the recorded by the remote, the drone. You can see the drone is moving little bit. There is a shaking, but still we can see all the vitals and parameters, and we can see the close view of the patient.
What is the purpose of using a drone? Yeah.
The purpose is to again maintain the distance and not to go near the patient. Don't give the disease, don't take the disease, and continue the work.
But could not that be done by the camera itself if you had an ICU?
Yes, that also we have. But the only thing is with the help of drone, you have a mobility. You can move the camera in different directions, whereas a fixed camera cannot move. It will be lying at particular position.
Yeah, we are ready to time. I request all the participants please wait for the presentation to complete, then you can interact.
Okay,
Time is up.
Yeah, another 2 minutes I will complete, sir. This is my last, second last slide. After that, we will explain. So we have developed the COVID studio, dedicated COVID studio, and internet radio. We have a app. We have a app, internet app. So where the now this is our director Rakesh Agarwal. He is giving a internet talk on the even though we may face hardship. Similarly, he's our jockey who is taking the questions from the presenter and then similarly we have a digital display system across the whole hospital. We have more than 100 display system where all the information related to COVID and the facility, it is being displayed. So in our display systems, which is developed by Ministry of Information and Broadcasting, so we don't show any cable movies or entertainment, or basically it should be used for education purpose, educate the public and give them awareness about the national programs. And we made a dedicated corona website where all the messages, all the information is there. And when you click the link, particular speech is there where the director is giving the talk for the faculty. The number of cases with COVID-19 is rapidly rising all around our country as well as in our region. And during this period, we studied all this work and we published it. So out of 15, some of them have been published and some are still in the process. And to summarize, around 4 lakh, we purchased some mobile and given to all the consultant in their department, and through mobile, when they are receiving a call through the call center, around 4 lakh consultations, clinic consultations. So this is the statistics, and all the education were continued, whether webinar, PhD Viva, UG, PG classes, counseling, guest lectures, COVID meetings, ministry meetings, meeting with WHO, ICMR. So we never stopped the work actually. So with the help of telemedicine, everything, e-prescription, around 2 lakh e-prescriptions were given to the patients. Live telecasts were done of various sessions. E-classroom continued. And in the rural center, we provided some dongle if NCAN is not there, and still we help them. And this is the award in telemedicine we got in 2014, in 17. And last month, I presented this work and we got this Scotch Award also. So it means whatever is the gap, it can be bridged with the help of telemedicine. And we are thankful to the ministry and the NKN and NMCN project, as well as our NRC mentors, Dr. Mishra and other RRC who are mutually cooperating and discussing the issues. Thank you very much.
So I thank you, Dr. Ravi, for giving elaborate presentation. It's self-explanatory, and all of you understood. And in this short time, you have really achieved a lot, and we appreciate that. And I think other people also emulate some of your applications and apply in their own system. Actually, we have consumed a lot of time, so I request the participant to bear with us. Our maximum 1 or 2 questions are only allowed.
I just want to congratulate the team for doing such phenomenal work so effectively in COVID times. And these are the kind of things which we need to take forward so that we can showcase telehealth, what it can actually do for the system. Thank you very much for the presentation.
Okay, so thank you.
Can I ask a question? Yeah. The nano drone was very, I saw the nano drone. It looked very, I've seen it only outside where the drug delivery is done. He has used it in the ICU. It was very effective too. A very nice concept.
Thank you for your comment. Is very, very encouraging. Sure, see, there are so many devices are in the market. You can apply to ask for your own requirement. So anything can be used in any environment. So you just require a design and also understand the situation where you can fit it. So with that, let's stop this particular session here, and I request Dr. Biman to take over the second presentation.
Thank you, sir. Thank you.
Is there?
Thank you, Dr. Mishra, and thank you, Dr. Ravi, for that excellent talk. And I think COVID-19 has been a boon to telemedicine because we get, explored so much, and with such kind of work happening, it's really encouraging. So with that, we move to our next speaker, Dr. N.K. Agarwal. Dr. N.K. Agarwal is a nodal officer of RRC Telemedicine at IMS BHU, Banaras. And he is also the Associate Dean Research and Professor of Endocrinology at BHU. Dr. N.K. Agarwal.
Thank you, Dr. Sakya, and thank you, Madam Singh, for inviting me for this talk. Can I share my slides?
Yes, sir. Please. Yes, Dr. Agarwal.
Yeah. As we know that communication at a distance has been happening, and the healthcare communication has been from time immemorial. So telemedicine basically focuses on improving the quality of healthcare in patients, building a virtual community of physicians, and increasing the convenience, efficacy, and decreasing the medical cost. The American Academy of Family Physicians basically defines telemedicine and telehealth as two different things, but telehealth is just a larger extension of telemedicine and wants the telemedicine to be conducted within the context of appropriate standards of care. So this telemedicine evens out the reach to the remote areas and provides a quality care to a less privileged people. So there can be decision support, education, clinical trial virtual visits, or research. The forms of telemedicine could be doctor to doctor, doctor to paramedics, doctor to patient, paramedics to the patient, or doctor to the patient group. Doctor to doctor, we have seen all these virtually elaborated very very highly by the JIPMER Pondicherry. So this telemedicine could be from doctor to doctor by case presentation, journal clubs, opinions, expert opinions, workshops, live surgeries that the landmark Lindbergh operation and the armed forces may have their benefits of battle casualties where they can use this system. The government of Uttar Pradesh has a ECCS facility, and we are part of a hub of the model, and we are providing the facility to the UP government, to the nearby L1 and L2 hospitals and the nearby private hospitals, so they can consult us for the electronic COVID care support system. The clinical application can be from doctor to paramedics or paramedics to the patient, like instructions and ICU care and general instructions or specialty instructions. ISRO helped in tsunami in a big way that the GBPAL Hospital, INHS Dhanvantari, Port Blair, Bishop Richardson Hospital at Car Nicobar, and ISRO Gramasat network at 8 islands all managed the tsunami which happened to us in way back. Then telemonitoring of healthcare facilities we saw just now. Then paramedic-based telemedicine services where patients can just take some instructions from paramedics, which we usually want. So this reduces the burden on the physician and improves the quality care. And it can be current guideline based, so improves the quality of care. Then there could be doctor to patients, like when patient is far from hospital, so seeks expert medical advice, connect with specialists, super specialist doctors through online, and saves unnecessary travel time, and minor ailments can be handled virtually. Is a pivotal role for live surgeries because we just saw that there could be a consultation during the surgeries also, and surgeons can tell the procedures and steps to be taken in during the procedure, and virtual post-op follow-ups can be there. Telemedicine is much advantageous in ICU. Just now we saw, and we have this can be there. Just to elaborate, obstetrics and gynecology can have wellness, well-women visits, preventive care, preconception, counseling, family planning, infertility workup, teleradiology, cervical cancer screening and colposcopy, mental health or telesurgery. Telecardiology could be there. Other branches like my endocrinology can have glucose, thyroxine, dose titrations, testosterone therapies, HRTs, and calcium maintenance, just hypopituitarism cases. Then gastro, nephro, telepathology, radiology, all these branches can have telemedicine usage. We can have doctor to patient group. We can create a group of the patients, and we can manage their day-to-day working problems and general do's and don'ts, special instruction. Patient can create their self-help groups and with the doctor, and there could be quality care for special diseases. We did have a telemedicine activity, and nearly 50,000 consultations were given through 17 specially dedicated mobile numbers, and we had also local district hospitals supported through ISRO. So we also conducted these, although these hospitals were mostly dedicated to COVID during this period. So the many branches were giving the telemedicine facility, and some once we gave connected to the Kargil. Then we are running through the eSanjeevani portal, and we are the hub for the 102 health wellness centers. So this is all part of the program. Telemedicine can be applied to drug trials like patient visits or virtual visits, which or telephonic visits, which were part of the drug trials, can be conducted. Data collection can be there. Serious and non-serious adverse events can be seen and and could be assessed. Ethical reappraisals can be done, and study monitoring or independent data monitoring can also be part of the telehealth. Could bring in more US healthcare expenditure, so it is possible, and it gives us access to faster access to regular checkups, lower service cost, and innovative care. There could be second and third opinion about it. Virtual exercise rehabilitation assistant system could be there. Radiology, cardiology departments could rely on artificial intelligence. Watch ECGs, as you know, Apple Watch has the ECG facility. The Google is trying to develop diabetic retinopathy and prediction of hospitalization by vital data. So this is all possibilities of the care. The barriers, as we all running through the program, saw that there could be legal implications of the consultations, and international laws are not very sure. Patients mostly rely on face-to-face interactions, and the data which we are getting for interpretation, how much are they be reliable, is a challenge. Connectivity issues, as we know that there could be areas where there is no mobile, the software are having glitches. The doctor-patient ratio still is a challenge, and there are no established protocols, training, and global compatibility of equipments. So these are the challenges which we have, but still we have to go on. Thank you.
Thank you, Dr. Agarwal, for that lucid talk, and that sort of summarized what we have seen in our previous talks. So if we have any quick questions to both the speakers. Maybe you can take one or two, or questions chat box. There are no questions in the chat box. So with that, I thank both the speakers, Dr. Ravi and Dr. Agarwal, for their nice talks, and thank you, Dr. Mishra, for chairing this session. And with that, I hand over to Amit for the next session. Thank you so much.
So we are now coming to the last of CME. We have our chairs, Professor Nusrat Shafiq, who's a professor of pharmacology and a very active member of our Cochrane network, as well as she's also the faculty for Telemedicine Center in PGI. She has many publications in reputed journals and also a member of many scientific societies. I would now hand over. Dr. B.S. Bedi is also a co-chair in this. We have already introduced him in the morning. So, sir, it would be nice to have you here. Dr. Nusrat, if you could please start the session and invite the speaker.
Thank you, ma'am. Thanks a lot for that elaborate introduction. Before we move on to the introduction on the speaker, I would like to let the audience know that Dr. Meenu Singh is also spearheading another. I wouldn't be overstating it if I say that another movement in the healthcare that is of making evidence-based medicine the basis for guiding practice. And her endeavors in this field have reached different heights. And in this context, we have what I could say an offspring of this endeavor, Dr. Nishan Jaswal, who will be our speaker for this session. And it is my proud pleasure to introduce Dr. Nishan Jaswal, who I have had the pleasure of knowing personally and working with him. And welcome, Nishant. That's how we call him here, because he's been such a junior colleague to us. So Dr. Nishant is working as a research associated, and he's affiliated to Health Economics, Health Technology Assessment Institute of Health and Wellbeing, College of Medical, Veterinary and Life Sciences, University of Glasgow. He has won the coveted Vaughan Kenneth Warren Award 2020 by Cochrane Collaboration, and it is a pleasure to read some of the systematic reviews which he has done, especially the ones that are related to vaccine. Without much ado, over to you, Dr. Nishant.
Thank you, ma'am. Am I audible?
Yes, you are,
Yes.
Dr. Nishant.
Thank you, ma'am. Thank you for such a lovely introduction, and it's always a pleasure to be to work with you, and I always like to be associated with PGI and Meenu ma'am and you. So it's a pleasure for me. So today I'll be discussing about the roles of systematic review in health informatics. So I'll just start. Is my screen visible?
So, Dr. Nishant, please go ahead.
Okay.
Yeah.
Thank you.
Quite visible.
So before I start my talk, so I'll just declare that the presentation is based on my experience during my previous roles as consultant health informatics and scientist, CARI, EBCH, the roles that I played in PGI while I was doing my PhD also. So health informatics. So this is a emerging branch in and it is a part of telemedicine, and it involves the intelligent use of information and technology to provide better care for patients. And in today's healthcare system, it is the most pervasive and transformational tool, that is the information technology, and its efficient use is very essential. So informatics is changing how healthcare providers and patients communicate. So this is a picture that depicts the ways of information between the patients and clinicians. So you can see, so we have patient and clinician interactions, we have a clinician and other clinician interactions, patient and other patient interactions. So every interaction is based upon high quality information. And so high quality information can be graded as systematic reviews, randomized trials, cohort studies, case control studies, and case series. So earlier systematic, this was the pyramid of hierarchy that was used, and recently there was a debate, and systematic reviews have been taken off, and they are now defined as the lenses to look at the available evidence, and which the COVID pandemic has. During the COVID pandemic, these systematic reviews have played a very crucial role to inform the healthcare. So we see during the COVID pandemic, it was like 56,000 articles were published, and of which 14,000 were randomized control trials, and these were only about the COVID-19 treatment. So which is a huge amount of information. And when we look at the systematic reviews, there were almost 1,200 systematic reviews. So all the information available in those 56,000 articles was summed up in these 1,200 articles, and of which 45 were the Cochrane reviews, and there were 10 Cochrane protocols. It includes some Cochrane clinical answers also. So these systematic reviews, they eased out the use of the available information, and they made the work so much easier for the clinicians, the healthcare providers, and as well as the patients to know what they want to what is the right choice of treatment. So, then there was then we came to know about the living systematic reviews, and although they were there in the business for quite a long time, but COVID-19 saw the use of living systematic reviews the most. And it is defined as a systematic review which is continuously updated and incorporating relevant new evidence as it becomes available. This means that but they are underpinned by continual active monitoring of the evidence. So they are updated either monthly, sometimes weekly, based on the available evidence. And if there is any new evidence that has come up, and it will be reflected very soon in the living systematic review, whereas in a routine systematic review it takes around 2 years to update it. And so the conclusions keep on changing very quickly in a living systematic review, and it keeps keeps everybody updated with the latest information. And so the COVID-19 crisis, the living systematic reviews were the ideal interventions to inform about the treatment modalities, also about the current vaccines, which vaccines are there available and which are better. So they are very helpful as a tool for the policymakers, as well as for the healthcare providers, and also the patients, because they are all open access articles, and they are very easily available. So they provide high quality information. So I would like to conclude that the systematic reviews are therefore a very essential part of health informatics, and without systematic reviews, health informatics is incomplete. So that is what I wanted to have to tell about systematic reviews. Thank you.
Thank you, Dr. Nishant. It was such a pleasure listening to your talk. Now I have with me my co-chair, Dr. H.S. Bedi, who has joined now. So would you like to say a few words? And Dr. Bedi, you were, I think, muted. Can you please unmute yourself?
Thank you. I was just mentioning that, Jaiswal, this is a very interesting topic which you are taking up for research, and we have in this pandemic, and now the second surge has come. A lot of huge amount of information, and people want to know about vaccines, their effects, and all that. People who have some kind. So I think this will be a very, very important information tools which will become available. This living systematic reviews in the healthcare and health informatic as applied to healthcare. Moreover, the health, it is very interesting how this informatics has really affected healthcare. I mean, the amount of improvement it has brought, and now even existing some modalities you are looking at, their effectiveness, this adds further feathers to the already important role which health informatics was playing in improving the healthcare delivery all around. I'm very happy that a very small and precise presentation was very meaningful. Thank you, Jaiswal.
Thank you, sir.
Yeah, I know. Otherwise, health informatic, I remember in early 90s when we had installed our indigenous linear accelerator. But treatment planning system used were of two dimensions. They used to take X-ray and then quantify the, where the tumor is and how to give the proper dose. The moment CT scanners came and all that, the three-dimensional treatment planning system, they changed the quality of treatment, reduced have been given to the tumor, saving the other tissues. So health informatics has a lot of this thing. And now, in existing crisis, when you bring out certain tools which further add to the knowledge, and people get decision to take decision, profitably, what will be the best for them, what vaccine will be best for them, which to avoid. This is, I personally feel, a very good activity. Thanks.
Thank you, sir. Thank you.
Thank you, sir. Maybe we can have a couple of quick comments if there are any. If none, then we come to the conclusion of this session. Thank you, Dr. Nishant, and thank you, Dr. Bedi, for joining.
Thank you.
Thank you.
So I think we now reach the end of our CME today. It's been really nice having all of you with us for so many hours. And thank you very much, Nishant, for being there. I know in UK, that's why we kept your talk a little late, because otherwise it could have been very much early in the morning. And we also had Dr. Vinayak Prasad join from Geneva when that was a little early in the morning. So in spite of the time differences and the time constraints, all of you have been with us. I really thank all the faculty and guest speakers for today's deliberations. I think we have had our feast on the Foundation Day, and I think now we can all go for a virtual lunch. Thank you very much.
Thank you very much for bringing up a beautiful CME, Foundation Day. Your celebration was so good, like your activity in telemedicine, promoting telemedicine from PGI. You are touching new heights, and at least that contribution to PGI from Chandigarh with your initiative is really remarkable and so much appreciated all around. Please keep up this activity, and I hope you are successful in getting a national that institute status also very soon. Our best wishes are with you, and with your efforts, I know things will go to great heights. Thank you.
Thank you very much, sir. Thank you, everyone. I think